Okay, then the analgesia can be used by continuous infusion, and then you can add the narcotics. They say if you add the narcotic, the overall local anesthesia requirement will be less potent, and then you can use that one. If you have to do spinal and do single shot spinal narcotics, then you should better to use facial point needed to reduce the chance of PDPH. And then there are centers that do CSC anesthesia also and patient control anesthesia also. They say patient control, the overall requirement of this local anesthesia becomes less with CC. If you do anesthesia for retained placenta, the same epidural catheter can be used for that, and G also can be given. There is no set rule for that. And now they use nitroglycerin also. So they can be used as an alternative to GA or renal anesthesia for this utilization to remove the placenta. Either tablet or metered dose spray can be used for that, or IV also nitroglycerin. So for cesarean, you have the same equipment and facilities which can be available, which should be available in the normal OR. You should also have in obstetric suits, and all these requirements. And you have any toxicity measurement, any emergency you should be tackling with. Choice of general epidural spinal or CSC anesthesia is yours. Usually in difficult cases, you can still go for GA. Otherwise, renal anesthesia is a method of choice nowadays. If there is rupture uterus, profound fetal bradycardia, severe hemorrhage, and severe placenta ablation, you can still go for GA. So I used to do it either preload or co-load. They said anything can be done, but there should not the initiation of the spinal should not be delayed because of this preloading thing for 6 volume. Ephedrine or phenylephrine, anything can be used, but they say if there is no bradycardia, better to use phenylephrine rather than ephedrine. For post-op anesthesia, after neonatal anesthesia, for cesarean, 5 minutes. Postpartum ligation, again, if it is just immediate post delivery, you can use the same catheter for that. Otherwise, you can go for GA, and but you should be aware that if the epidural catheter placed for labor may more likely will not work properly if it is delayed for 2-3 days. So now we come to what we should have for if we encounter any obstetric hemorrhagic emergencies. There should be large bore IV cannula, fluid warmer, force air body warmer, blood bank should be there, massive transfusion protocol, equipment of infusing IV fluids and blood products rapidly. This level 1 infuser or whatever should be there. And whichever institute providing obstetric care should have resources available to manage hemorrhagic emergencies. Type specific or O negative blood should be acceptable in these cases. And intractable hemorrhage, and if there is no patient doesn't accept the blood transfusion, you can use salvage technique. Then there should, if there is any airway equipment, we should have laryngoscope and different sizes, tube, oxygen source, suction source, self-inflating embryo bag, and medication for blood pressure support, muscle relaxation, and hypnosis. So all delivery suits should have this personnel and equipment ready for that, and basic airway management equipment should be immediately available during the provision of neuraxial analgesia. Portable equipment of difficult airway should be readily available in operative areas of labor and delivery suits. Airway emergencies, pretty formulated strategy should be there for difficult airway. And then if tracheal intubation fails, then you should have any alternative airway like LMAs. And if not possible to ventilate or awaken the patient, surgical airway should be performed. Then again, what should we have there for difficult airway, rigid laryngoscope, video laryngoscope, and for thoracotomy equipment, we should all have. Okay, if patient, God forbid, go to cardiopulmonary arrest, then should be resources for cardiopulmonary resuscitation. Also, there should be a team available, and basic and advanced life support equipment should be immediately available. If cardiac arrest occurs, initiate standard resuscitative measures. Uterine displacement should usually on the left side should be maintained. If maternal circulation is not restored within 4 minutes, cesarean delivery should be performed by obstetric team. So these are the main sources of these guidelines which are just presented. If anybody wants to get the more scientific knowledge, they can go to these sites and get the references and the strength of the evidence which is behind these recommendations. Thank you very much.
Thank you. Our third speaker of the session is Dr. Furqan Haider. He is a consultant anesthesiologist at Sindh Infectious Disease Hospital and Research Center and Cancer Foundation Hospital. He has 2 publications in Pakistani Journal, post FCPS, 2 years experience in oncology, dealing with gynae oncology, head and neck oncology, uro-oncology, general surgery oncology, and thoracic oncology. He is in charge of anesthesia department at Sindh Infectious Disease Hospital and Research Center. Dr. Furqan Haider.
Assalamualaikum. I'm very thankful for the committee and the scientific committee that gave me opportunity to talk about standardized care for bariatric patients. Learning objective, understand the impact of obesity and related health condition upon provision of anesthesia, identify the high-risk obese patient, plan safe and individualized perioperative care determined by comorbidities and extent of surgery. Epidemiology, prevalence of obesity has tripled over past 40 years. More than 650 million obese adults worldwide. Increases are greater in developing countries compared to the developed countries. So how we categorize the obesity? Obsolete classification that includes morbid obesity, super obesity, super morbid obesity, and super morbidly obesity. We have the BMI that is scaled to categorize the obesity, body mass index that is weight in kg, per height in meter square, that is easy to calculate, can be useful to alert teams and allow planning and preparation. It does not describe the composition and distribution of body tissues, muscle, and adipose or metabolic state. So this is the WHO classification of obesity and the ASA grade. Underweight less than 18.5 BMI, ASA grade 1. Normal weight 18.5 to 24.9, that is AC grade 1. Overweight, anything above 25 is overweight, and it is also includes an AC grade 1. Pre-obese 25 to 29.9. Obesity is above 30, and class 1 obesity is above 30 to 34.9. Class 2 is 35 to 39.9, that is AC grade 2. And class 3 that is above 40 and it is SA grade 3. So what is the WHO definition of obesity? It defines as a waist circumference greater than 102 centimeter and greater than 88 centimeter for men and women respectively. And in Asian population, it is above 90 centimeter and 80 centimeter. So the distribution of fat, we have the 2 types of obesities. One is the central obesity and other is the peripheral obesity. Central obesity is also called as apple and the peripheral obesity is called as a pear-shaped obesity. So what are the health conditions associated with obesity and suggestive features and perioperative action required? So respiratory symptoms, we might have sleep disorder breathing, obstructive sleep apnea, or obesity hyperventilation syndrome. The suggestive feature, the clinical features that we might patient present with short of breath, saturation greater than 95% at room air, and we have stop bank questionnaire to identify the patient who are at risk of obstructive sleep apnea and obesity hypoventilation syndrome. The predisposing factors are BMI greater than 30, hypercapnic awake, raised bicarbonate, hypoxia, and exclusion other cause of hyperventilation. So what actions we might require before surgery? We have to do ABG initially and then a spirometry. If both are having some findings, then we can go with the cardiopulmonary exercise testing. And as we identify the patient have obstructive sleep apnea, we might have airway planning for this patient, refer for further investigation and treatment if required, commence CPAP before surgery and continue after surgery. BiPAP sometimes necessary for improvement in symptoms, especially obesity, hyperventilation syndrome, and we might have planned for post-operative ICU and HDU admission. And obesity might have asthma, and patient might present with dyspnea or wheezes, and that is not reversible with beta-2 agonist. The weight loss is the treatment for these asthma. So cardiovascular condition, the patient might have hypertension, left ventricular hypertrophy, left ventricular failure, conduction abnormalities, and cardiomyopathies, right heart failure, and reduced functional capacity. The clinical feature that might patient present with clinical sign of heart failure, history of cardiac syncope, increased systolic blood pressure, reduced exercise capacity, pulmonary hypertension, polycythemia, and difficult to assess in obese patient, that is functional class. And ability to achieve 4 mates, these patients are by default low risk for the perioperative morbidity and mortality. So what actions we might need? Preoperative resting ECG, echocardiography can be considered if there is suspected structural or functional disease, and we might need referral to the cardiologist for further optimization. Medical management and optimization might be necessary before surgery, and assess ability to walk on flat level surface and access climbing of stairs and cardiopulmonary exercise testing. Sometimes we need not routinely in, but it might required in high risk patients. So metabolic disorders that is related to the obesity, one is diabetes mellitus. Patient have deranged serum glucose, HbA1c is greater or associated complication. So we have to optimize glucose control with referral to the endocrinologist, avoid delaying surgery based on HbA1c concentration only is not always required. So liver involvement, evidence of cirrhosis and deranged LFTs, liver shrinkage diet, we might, that is high protein diet, less than 1000 calories per day. And other metabolic syndrome that are associated with obesity are central obesity, hypertension, impaired glucose handling of diabetes, increased triglyceride, and decreased HDL cholesterol. So actively seek component of metabolic syndrome. If 3 are present or more, that is diagnosis for the metabolic syndrome. So pre-operative assessment and risk prediction. Most important factor that we have to identify when we are dealing with the obese patient, that obesity is central or peripheral, because complications are more in central obesity rather than peripheral obesity. And metabolic, that is METs, ability to climb 4 flights of stairs, and peripheral oxygen saturation of less than 95% at room air. These patients are at low risk. So factor known to increase unanticipated admission to critical care, that is diabetes mellitus, chronic respiratory diseases, and open abdominal surgery. So this is one of the scoring that is obesity surgery mortality risk scoring system. We have the 5 components of it, that is BMI, if it is greater than 50, male, gender, hypertension, age greater than 45 years are risk factor for pulmonary embolism, just like previous venous thromboembolism, pre-operative vena cava filter, obstructive sleep apnea, or obesity, hypoventilation syndrome, right heart failure, or pulmonary artery hypertension. So each scoring of 1, if it is greater score, that by default, the patient is higher risk for the mortality for when we are dealing with the obese patient. So When we are giving the anesthesia for the obese patient after doing detailed preoperative assessment, organization and equipment, that is very important. One thing that is preparation of and the dignity. The dignity is very important in obese patient. We might need proper clothing for the obese patient. We might need proper stature, proper size of beds to dealing with the obese patient. Moving in positioning is very important because we need a lot of manpower to shift the patient from one bed to another bed and from OT table to the stretcher, and positioning because they are by default higher risk for the peripheral nerve injuries, compression injuries. And monitoring, we might need special monitorings like invasive arterial monitoring, and ventilation is quite tricky in obese patient. We might need high peak ventilation and ultrasound. And obese patient, as we know, we can't use much more opioids. So we can aid in the ultrasound guided regional blocks while dealing with the obese patient and the post-operative care. So monitoring, as we know, the standards of ASA, the qualified anesthesia personnel should always be present in the room throughout the conduct of all general anesthesia, regional and monitor anesthesia care. Apart from that,
You are left with 5 minutes.
oxygenation, ventilation, circulation, temperature, we might need central line monitoring, invasive arterial and WIS monitoring. So the conduction of anesthesia, the intubation is very important. I have posted 4 diagrams. There's a neutral position of head and head elevate and sniffing in the REM position. The REM position is always very good for the obese patient because it increases comfort. FRC is maintained, reduce chances of dyspnea, and backwash ventilation is facilitated and laryngoscopic view is improved. So airway, obese patient are by default having a difficult airway. Routine RSI is not indicated. We have to see the patient might have symptoms of regurgitation or any other complication. So it's not always required. Awareness, there is a chances of awareness in obese patient. Why? Because we might give underdoses. We might not calculate the exact doses that is required to anesthetize these patients. And we should know the principle of drug dosing. We might, some drugs that are lipophilic, some drugs that are hydrophilic. So we might need total body weight, lean body weight, and ideal body weight. On a rough scenario, the lipophilic drugs like induction agents are given as a total body weight, and what the water soluble drugs that are given with the ideal body weight. So maintenance of anesthesia, the TIVA is a very good choice for anesthetizing the obese patient because not accumulated in the fat, having a short half-life, very low active metabolites. Inhalational agent, patient can, especially the obstructive sleep apnea patient, might having a symptomatics because of the hangover effect of these drugs. Ventilation is very important. We might consider opioid-free analgesia. So post-operative care, when we extubate the patient, always consider that these patients should be extubated at 30 to 45 head position to maintain the FRC and to prevent the atelectasis, use of early CPAP and good analgesia. So daycare surgery, appropriate for daycare surgery, any BMI, patient-specific factor, anesthetic factor, and the surgical factor. On patient-specific factor, any BMI, good functional capacity, obstructive sleep apnea, obesity, hypoventilation syndrome effectively treated by CPAP and NIV, able to continue VT prophylaxis at home. These patients can safely be done in the daycare cases. And anesthetic factors, adequate time on list to anesthetize, regional anesthesia possible, experienced anesthetics, theater, and the day case ward team. Adequate time on the surgical factors are adequate time on operating list to perform surgery, taking into account expected time to discharge, and appropriate equipment for surgery and post-operative care available. Inappropriate for daycare, poor functional capacity, unstable hypertension, ischemic heart disease, congestive cardiac failure, unstable respiratory disease, previous VT, metabolic syndrome, are obesity surgery mortality risk scoring greater than 4 and 5. And the anesthetic factor likely to require long-acting potent opioids. So most common procedures for obese, we have the restrictive, malabsorptive, sleeve gastrectomy, need routine intubation, and malabsorptive Roux-en-Y gastric bypass and one anastomosis affect bioavailability of oral medication, just like postoperative analgesia absorption and adjustable gastric bending that have a high risk of aspiration. Routine rapid sequence induction is recommended with antacid pre-medication. Avoid NG tubes. Bend should not be deflated. Thank you.
Okay, thank you, Dr. Furqan. So our next speaker is Dr. Samina Ismail. Dr. Samina Ismail holds the position of professor at the Department of Anesthesiology and Intensive Care, Khan University. Her main research interests are obstetric anesthesia, regional anesthesia, and pain management. She has contributed to a number of scientific publications and book chapters, and currently she is the reviewer of a number of national and international journals. Dr. Samina Ismail.
Thank you, Dr. Alia, for the very kind, and I would like to thank the organizing the scientific committee for inviting me and for this very important topic that has been added, the standardized care for geriatric patients. Because according to the WHO report, the number of the elderly patients are going to be doubled by 2050. So we are going to encounter more and more of these patients with medical problems, surgery, and anesthesia. Although anesthesiologists are developing strategies to deal with these patients, but still there are areas of certain concern. So the roadmap, so what I'm going to talk in next 15 to 16 minutes is the pre-anesthetic consideration for geriatric patients. According to three conceptual categories, as we all know, is preoperative considerations, intraoperative management, and postoperative problems in these patients. So preoperative preparation of elderly patients, I think, is the most important thing, because your smooth postoperative, intraoperative, and the postoperative course is dependent upon how good you evaluate these patients preoperatively. So the comprehensive geriatric assessment, or the CGA, in the preoperative period includes this systemic evaluation of comorbidities, functional status, neurocognitive function, sensory impairment, and frailty index, and medications. And it has been shown in the studies that the CGM has positive impact on the postoperative outcomes in older patients undergoing elective surgeries. So this is a checklist for optimal CGM, and this is from the best guidelines, from the best practice guidelines from the American College of Surgeons, National Surgical Quality Improvement, and the American Geriatric Society. Excuse me, can you please either go out or just be quiet? Excuse me, the people at the back, because it's a little bit disturbing. So according to this checklist, in addition to the complete history and physical examination, we have to do cognitive ability and capacity, assess the patient for depression, delirium, any alcohol or substance abuse in these patients. Then you need to do cardiac evaluation according to the American College of Heart Association. Then we have to assess these patients for postoperative pulmonary complications. And then the functional status and frailty score that I'm going to talk about is very important in these patients. And then nutritional status, in the medication history, there are polypharmacy in these patients. And then you need to discuss the treatment goals and the expectations of the family and the patient, that what is required. So the neurocognitive assessment, is very important. So optimal geriatric assessment of geriatric patients, according to the recent American College of Surgeons, ACS, and Geriatric Society guidelines, they say that neurocognitive assessment before surgery is very much important in these patients. as dementia is associated with long-term care admissions, long hospital stay, higher mortality and poor prognosis in these patients. So we need to do neurocognitive assessment in these patients. So Mini-QoG is recommended as a short, easily applicable, well-studied tool. Now, this cognitive assessment has these are 3 items. A recall item, you ask the patients to give them a few words and ask them to recall. And then clock draw, you ask the patient to draw a clock and put the numbers in it. So these are the Mini-QoG, which I have given. It's easily accessible in the net, and I can even share my presentation with you. And how do you interpret this Mini-QoG? It is done by scoring. There's 3 items for the recall, and 2 points is given for the clock draw. And if the patient score is 2 or less than 2, then the patient has some possible cognitive impairment. And if it is more than 2, then the patient doesn't have any impairment. So Mini-QoG is recommended for every elderly patients. Then screening of depression is very important. We don't look into it, but we need to ask the patients the following simple 2 questions, as I've shown over here. And if the patient says yes to any of these questions, then further evaluation is definitely required in these patients. And then further, you need to refer these patients to specialized care in these patients. And then the risk factor. Now, these are all the risk factors for postoperative delirium in these patients. Now, which is you have already done the cognitive impairment. If the cognitive impairment, then these patients are going to develop postoperative delirium. Then any chronic diseases or metabolic or functional impairment in these patients. And if the patient is older than 70 years of age and number of polypharmacy, then these patients can develop postoperative delirium. And as I shown before, these patients, then the postoperative morbidity and complications, they increase in these patients. Then cardiac evaluation. Older patients are more vulnerable to perioperative cardiac events. So it's very critical to identify these patients who are at risk of developing cardiac complications. So determine appropriate perioperative management in these patients and effectively communicate the operative risk in these patients to the family, and discuss with the surgeon that whether surgery would do more harm to these patients or would be beneficial to these patients. Then ideally, every patient who have evaluated the patient and you suspect that these patients have some cardiac risk, then it's better to undergo these patients. They should undergo cardiac test and risk stratification, and optimizing strategies should be developed in these patients. And a web-based risk calculator is available, which is ACS National Surgical Quality Improvement. It's available, it's web-based, and then every geriatric patient should be evaluated on these risk calculator to determine actually where we stand in these patients. Then pulmonary evaluation. Now, pulmonary function declines with age. Why? Because there is loss of both lung and chest wall compliance. There is problem with oxygen diffusion capacity, especially if the patient is a smoker. So studies have shown that pulmonary complications are an independent predictor of mortality in these elderly patients. And what are the risk factors for postoperative pulmonary complications in the elderly patients is if these patients have aged more than 60 years and advanced age, ASA classification 2 or more, if this patient have physical impairment, physical dependence, if they are suffering from chronic obstructive pulmonary disease or congestive heart failure. So all these patients are at high risk to develop postoperative pulmonary complications. Then frailty, frail, is from the English word frail. Evaluation of the patient for frailty syndrome and documentation of this is the most important thing, which we, I think, overlook when we are dealing with these patients. And frailty is a syndrome of decreased physiological reserve and resistance to stressors. And it is a very clinically distinct entity from comorbidity and disability. So frailty score is different, and it depends upon these criteria. So if the patient has shrinkage, which means then unintentional weight loss or weakness, that is decreased grip strength, exhaustion, that the patient says that he self-reported poor energy and endurance, and low physical capacities, that is low, patient doesn't really, active, up and about and active, and slowness, there's a slowness of the gaits. So that if the patient receive 1 point for each of these scores, if the patient has 0 to 2, then the patient is okay, not frail 2 to 3, and intermediate between 4 to 5. So these are all the frailty score that you need to identify in these patients. And the nutrition. Now, nutrition is very important. So perioperative, now it says that perioperative oral nutritional supplements should be provided to these patients because they have positive effect on total serum protein, fewer complications such as wound, respiratory, and urinary tract infections, and they counter affect the poor appetite and illness in these patients because these are poor appetite. They don't have teeth, so they are not able to eat properly. So all these factors, if you provide perioperative nutritional supplements, so it can have these positive effect on these patients. However, no clear effect on mortality was seen by providing perioperative oral nutrition supplements to these patients. So prolonged preoperative fasting should be avoided in these patients, except in cases with intra-abdominal pathology. So we need to prevent, so we need to time the surgeries accordingly. Now, polypharmacy, now ACS and AGS best practice guidelines. Okay, I have 5 minutes. Thank you.
You're left with 5 minutes.
5 minutes, I know. So the ACS and AGS best practice guideline for optimal preoperative recommends that whenever possible, the unnecessary drugs should be discontinued, and the possible the new medication should be kept to a minimum in these patients. Now we come to the intraoperative management. Now, after doing all the preoperative assessment, which is, I think, is the most important thing, you need to decide that whether these patients should undergo surgery or not. You need to discuss with these patients. And then there are a number of other things also, like I'm going to talk about, like the mode of anesthesia. The mode of anesthesia there are no specific recommendations about the mode of anesthesia, whether it's general anesthesia, the regional anesthesia is more important. And the mode of anesthesia may only play a secondary role in mobility, rehabilitation, and discharge. However, high risk of mortality and hospital stay is seen in patients who are given GA or whenever there's a conversion from general anesthesia to regional anesthesia. And GA was associated with readmission, hip replacement surgery have compared the continuous spinal with SWAS compartment block, and have they seen that SWAS compartment block was associated with less hemodynamic changes. Anesthetic pharmacology, we need to consider in these patients as there's a difference of pharmacodynamics and pharmacokinetic in these patients. There's a prolonged onset time for induction agent, and there's increased sensitivity of these agents. So the recommendations for standardized care is to lower the dose, and the depth of anesthesia should be monitored with this monitoring or whatever. Neuromuscular block, the dose of NVA should hardly be reduced in these patients. However, the duration of action of neuromuscular blockade is prolonged in this patient. So monitoring is required, like pain of monitoring is required in these patients. Reversal agents are fine. You can use these, no problem with that. Monitoring, yes, if you're using major surgeries and arterial blood pressure monitoring and glucose testing and is required in these patients. Central venous pressure only if you require an additional route or you need to give vasoactive drugs in these patients. Just set a suitable limit of blood pressure in these patients so they don't get a fall of systolic blood pressure less than 20. Depth of anesthesia and neuromuscular monitoring is recommended in these geriatric patients. Goal-directed therapy have not really shown that they have decreased the length of the stay or reduced complication or 30-day mortality. However, in high-risk patients, goal-directed therapy significantly reduced. It has shown significantly reduced mortality and morbidity in these patients. Blood transfusion, either there's a choice between liberal transfusion, that you don't allow the hemoglobin to fall. You start transfusion if the hemoglobin is less than 9, keep a range of 9 to 10, or restrictive, that you start transfusing if the hemoglobin falls 7.5 and keep the range between 7.5 and 9. However, liberal transfusion have shown reduced major adverse events after non-cardiac surgery. Lung protection ventilation, they have recommended ACS and have recommended care bundle, which should start before surgery, supervise exercise programs, and during surgery, use a low tidal volume, use a PEEP, recruitment maneuvers should be used, monitoring to avoid hyperoxia and limit neuromuscular blockade. Post-operatively, breathing exercise, important. Now, post-operative adverse outcome and post-operative anesthesia. These patients would develop, 21% have shown to develop adverse outcomes, and 3.7% they die, these geriatric patients. Especially if the patient has higher ASA classification, emergency surgeries, or intraoperative. So we need to assess these patients preoperatively and plan the intraoperative management to prevent postoperative adverse outcome. Postoperative anesthesia, multimodal anesthesia is the best in these patients. Paracetamol is recommended, and NSAIDs should be used with caution. Although morphine is effective, but you have to adjust the dose accordingly. Regional anesthesia as a part of multimodal perioperative treatment should reduce postoperative neurological, pulmonary, cardiac, and endocrine. So whenever possible, just add regional technique as a postoperative anesthesia for these patients. So conclusion, although the guiding evidence remains poor so far for elderly patients, but these patients need a good perioperative care by interdisciplinary, interprofessional, and cross-sectional collaboration to minimize unwanted postoperative outcomes, because these patients do develop adverse outcomes. So thorough preoperative assessment, I think the thorough preoperative assessment is the key. And then you can accordingly plan your intraoperative and postoperative care in these patients. Thank you so much.
Thank you, all the presenters. Really, our presentations are very excellent, concise, and well correlating with the theme of the session, that is standardization of care among different populations. Now we have a 10-minute session for question answer. Being the chair of the session, I don't have personally any question, but rather a comment. Over the past few years, field of anesthesiology has made a tremendous development, and that is why now in modern world, we anesthetists are called as perioperative physician. So it is the right time to take it further for the standardization of care among different age groups. Unfortunately, in our part of the world, we are lacking in resources, staffing, and equipments. And top of the all, we are deficient in streamlining standard operating procedures. So to overcome these all, we need to have protocols, SOPs, basic equipment, and definitely standard monitoring throughout the operative period. Thank you.
Assalamu alaikum. I'm Dr. Safar Zada, a resident of anesthesiology at NICDD, and I would like to now invite our chairperson to please distribute the certificates to the speakers. Thank you. Firstly, I would like to invite Dr. Esma Abbas on the stage to please come and receive his certificate. Thank you.
Rakhawar Aziz.
I would like to invite Dr. Furqan Haider to please come on the stage and receive his certificate. Thank you.
Professor Samina Ismail.
I would now request Dr. Saleh Khasteli to please come on the stage and distribute the certificates to our chairperson. Thank you.
Professor Alia Ahmed. Dr. Mohammad Sherar Ashraf. Thank you. Assalamu alaikum. I'm Dr. Rabila Hashmi, second year resident in Ziauddin, Hospital. Assalamu alaikum. I'm Dr. Sadaf Khan, ART resident from Dr. Ziauddin Hospital. I'll call Dr. Professor Noorul Haq on stage. He's HOD anesthesia and pain medicine at Hamdard University Hospital, Karachi. He is examiner of FCPS pain medicine. He has also worked as president PSA Center from 2018 till 2022. At that time, he has also worked at President SARC from 2018 till 2022. He is a regular examiner and paper setter of MCPS intermediate module and FCPS anesthesia since 2005. He has more than 25 research articles in national and international journals. He's an instructor of BLS, PTC review of different journal of Pakistan like JPMA, JCPSP Annals. Please welcome on the stage. Thank you. I'd like to call Professor Nigat Abbas. She's a professor consultant at Liaquat National Hospital and Medical College, Karachi. She's also a principal in Liaquat National School of Medicine Technology since the last 6 years and till date. She's an ex-head of Department of Anesthesia, Critical Care and Pain Management. Moreover, she has multiple research publications at national and international journals.
शुरू करें I welcome you all people at this hall. I am sure that people will enjoy the pros and cons session. So our first speaker will be Dr. Rabia Iqtidar, and she is from NICVD. Please welcome. She will be talking on are all aseptic measures, including gowning and gloving mandatory for spinal epidural and central aligned placement. And she will be talking on the pros. Okay, welcome.
Assalamu alaikum everyone. I'm Dr. Rabia Iqtidar, working as assistant professor in Department of Anesthesia and Critical Care, National Institute of Cardiovascular Diseases. And today I will be talking in pros of all aseptic measures, including gowning and gloving, which are mandatory for spinal epidural and central line placement. In my talk, I will be focusing on the CDC guidelines. These are the guidelines of Center for Disease Control and Prevention for the prevention of intravascular catheter-related infection, evidence-based practices, which are based on the published data and literature review, practices in Pakistan, for the central venous catheter, intrathecal and epidural catheter insertion. And we have a final conclusion. Okay, so CDC guidelines, actually these guidelines have been developed for the healthcare personnel who insert the catheter, intravascular catheter, as well as for the host person who are responsible for the surveillance and control of infection in hospital, outpatient department, as well as in home healthcare services. So in my talk, there is a system of categorizing recommendation in this guidelines, but in my talk, I will be focusing on category 1A, which is strongly recommended for implementation and is strongly supported by the well-designed experimental, clinical, or epidemiological study. Okay, so as everyone is quite familiar that before we perform any invasive procedure, there are certain steps which are required. So that include the hand hygiene and aseptic technique. This is the starting step before we perform any invasive procedure. So the guidelines recommendation for the hand hygiene and aseptic technique is to wear sterile gloves. Sterile gloves should be worn for the insertion of arterial, central, and midline catheters supported by the category 1A, which is a strong recommendation. Regarding maximum sterile barrier precautions, use maximum sterile barrier precautions, including the use of a cap, mask, sterile gown, sterile gloves, and a sterile full body drape, which is similar to the drapes done in operating room for the insertion of CVC picks and guide wire exchange, supported by the category 1B. For a skin preparation, prepare clean skin with a 0.5% chlorhexidine preparation with alcohol before the central venous catheter and peripheral arterial catheter insertion and during dressing changes. If there is a contraindication to chlorhexidine, then the alternatives are the tincture of iodine or an iodophore is supported by the category 1A, or recommendations in CDC guidelines is a strong recommendation. So these guidelines were updated in 2011 with the addition of chlorhexidine in patients who are younger than the 18 years age group, while in younger group, less than 18 years or especially the 2 months, this is not indicated because of the anticipated high risk of severe adverse skin reaction. Okay, so it's all of us know that the hand hygiene itself can reduce the high risk of incidence of infection, and it has been stimulated and emphasized by the WHO. WHO clearly says nationwide that the clean care is the best care. So I would emphasize that perform hand hygiene procedure either by washing hand with conventional soaps or with water or alcohol-based hand rubs, supported by category 1B in the recommendations that has been published in the guidelines for the Center for Disease Control and Prevention of Intravascular Catheter Insertion. So the final step before for performing or securing any catheter is the secure of the catheter site. And for this, we have a recommendation in the same guidelines that use either sterile gauze or sterile transparent semi-permeable resin to cover the catheter site, supported by or recommended by category 1A. So how can we improve our performance? In the same guidelines, there are the recommendations that use hospital-specific or collaborative-based performance improvement initiatives in which multifaceted strategies are bundled. Remember, the group of actions are required. So they are bundled together to improve the compliance with evidence-based recommended practices. Okay, so in my talk, I will take the help of these published data and the literature. This is the central venous catheter insertion checklist for the critical care, and they have emphasized regarding sterility and personal protective precautions. Hat, mask, gloves, gown, and fenestrated drape and eye protection should be worn. Okay, so this is an updated report by the American Society of Anesthesiology Task Force on Central Venous Access Practice Guidelines for CVP published in 2020. They had the survey, and their survey findings included that the consultant and ASM members strongly agree with the recommendation to use aseptic techniques, for example, hand washing and maximum barrier precautions that include the wearing of sterile gloves, sterile gown, cap mask, or covering both the mouth and the nose, and a full body patient drape in preparation for the placement of central venous catheter. Again, this was a policy that was made and strongly practiced in NHS, in Trust Hospital NHS. And they also had the strong recommendation for wearing of sterile gown, gloves, and large shapes for the insertion of central venous access catheter. So I'm quite clear here. This you can see a proper prep and rep is required prior to the insertion of central venous catheter line. And a person or a healthcare person must be wearing a sterile gown, a sterile gloves, and there should be no risk of contamination of the central venous catheter to come in contact with the foreign body or particles. So in this way, the healthcare personnel itself can reduce the risk of infection. So this is a complete sterile field for central venous catheter insertion. And in this diagram, you can see that the use of ultrasound machine in current era is indicated for more accuracy. But remember that the ultrasound machine probe should also be covered in sterile sleeve. It carries the high risk of contamination. So I'm done here with the central venous catheter. Let's start with the epidural block and spinal anesthesia. As everyone of us are quite aware that there are certain aspects that need to be considered, as it may carry the high risk of infection and can complicate the infectious process during the single shot puncture or while an epidural catheter insertion. Okay, so this is the regional anesthesia safety recommendation update published in Brazilian Journal of Anesthesiology, published in 2020. The main goal of this literature or the paper is to provide an overview regarding the diagnosis, infection, treatment, and the prevention of the complications that were associated with the neuroaxial anesthesia. Here you can see that the infection complication associated with the neuroaxial anesthesia can be devastating, such as meningitis. And remember that bacterial meningitis is a medical emergency, and if it is here, then it carries a high risk of mortality, 10 to 30%. Ultimately, paralysis and death, big mortality. The estimated risk of major infectious complication is about 1:40,000, according to the data from the third national audit project of Royal College of Anesthesiologists in the UK, in which 15 epidural abscesses and 3 cases of meningitis were reported in 700,000 neuroaxial anesthesia. So remember that literature include the big publication sources that were published in the year in between 2011 and 2019. And few of the publication in the same literature included from the year between 1965 to 2011. So according to the audit, epidural anesthesia or analgesia was associated with a high chance of complication when compared to the spinal anesthesia. This is because in a single shot puncture, you go in and you came out, while in epidural, the catheter stays here and there is a high risk of contamination because of the longer duration of exposure. Okay, these are the combined safety guidelines, which is formed by the combined efforts of obstetric anesthetists, pediatric anesthetists, and the regional anesthetists of the Great Britain and Ireland. Again, to emphasize regarding the infection control precaution for the central neuroaxial block. And these included that the thorough hand washing with the surgical scrub solution, the wearing of a cap, mask, sterile gown, and gloves, and the use of large sterile drape. Okay, these are the few tips that has been published in NITSORA. I have picked the one that sterile gown should be worn during the insertion of epidural or nerve block catheter. So these are the guidelines regarding the infection control. Actually, these were the broad guidelines, including both the general anesthesia and the regional anesthesia, and they have published regarding the infection control recommendation for regional anesthesia and included the maximum barrier precautions measures. Jewelry should be removed and hands should be washed. This is specifically for the anesthetists, as they are more commonly performing the
5 minutes more.
invasive procedures. So don't forget to remove these products. Cap, mask, again, the maximum sterile barrier precautions, they should be wear sterile gloves and gown, and sterile drapes should be there. And the recommendations are mainly based on the practice advisory produced by the American Society of Anesthesiology, guidelines produced by the Association of Anesthetists of Great Britain and Ireland, Australian and New Zealand College of Anesthetists also had the similar recommendation. Okay, we all of us cannot forget the COVID. This is the practice recommendation after the emergence of COVID-19 pandemic. Shortly, I can review here. They did not say that the COVID patient is contraindication for the regional anesthesia. No, they can go with ahead but the personal protective equipment should be there and use of complete aseptic and sterile measures should be taken. And the patient who is positive should be wearing the surgical mask. Based on all the data that I have shown here, I think we all can easily conclude regarding the aseptic technique during the central venous catheter that central venous catheter are frequently required for the therapy in hospitalized patients. They may present a source for the bloodstream infection, that is a central line associated bloodstream infection, CLABSI, and thus may increase morbidity and mortality of this patient. Hospital costs are directly related to CLABSI, and we all agree that the CLABSI have a significant impact on the overall healthcare cost. Therefore, the knowledge about the infection control, measure, and prevention for CLABSI is crucial for the best clinical practice. Regarding the aseptic technique during regional anesthesia, studies have shown that the patient develop infection after the neuroaxial anesthesia, and the epidural catheter infection can occur by dissemination of cutaneous flora that migrate along the catheter, contamination of infused solution either or with the blood-borne dissemination from a distant source. So therefore, the recommendations are intended to encourage quality care, patient care by practicing strict aseptic measures, thorough hand washing, and maximum barrier precautions that include the wearing of sterile gloves and gown. So what are the practices in Pakistan? As per our knowledge that we have gathered from the big tertiary care hospital, in most of the tertiary care hospital are religiously practicing all aseptic measures during central venous catheter insertion and neuroaxial block. So I think I'm quite clear here. This is a statement, that's not mine. This has been the statement endorsed by the American Society of Anesthesiology, European Society of Anesthesiology, Brazilian Society of Anesthesiology, and had been endorsed by the South African guidelines regarding the infection control. No question arises beyond that, that the strict aseptic measures with maximum sterile barrier precaution should be followed before the insertion of any invasive catheter, including the central venous catheter or central or neuroaxial block and spinal anesthesia. Thank you.
Thank you.
Thank you, Dr. Rabia Iqtidar. Our next speaker is Dr. Akbar Mistry. Dr. Akbar is currently working as a consultant at Ziauddin Hospital, Clifton. He is an AKU graduate with fellowships in general anesthesia and cardiothoracic anesthesia. He is also heading the anesthesia department at the pediatric cardiothoracic unit at SIUT. Dr. Akbar Mistry.
Assalamu alaikum, everyone. The reason why this presentation is so short is because I could not find much to speak against the topic. So I have the same topic, but I have to speak against it. So what are the commonly performed procedures? As NSSs, we perform the following procedures. So there's IV cannulation, which is performed either using latex or plastic gloves. Then there's arterial line insertion, mostly performed using sterile gloves after cleaning the site using pyridine or chlorhexidine. Then there's central line insertion, often performed wearing gown and gloves after cleaning the insertion site using either pyridine or chlorhexidine. Then there's epidural insertion. At most centers, it is performed using disposable sterile gowns and gloves after cleaning the site with aseptic, antiseptic solutions. So the question is, how essential is it to wear gown and gloves for these procedures? We'll talk first about central neuroaxial blocks. So ASA had conducted a vast literature search as well as large scale surveys to evaluate the variety of practices used for central neuroaxial blocks with respect to sterility. Literature shows no difference in the development of meningitis or insertion site infection between subarachnoid block when it is compared to epidural catheter insertion. However, general consensus of the members of ASA was to avoid central neuroaxial blocks in patients who have infection or abscess at the site where the needle has to be inserted. Literature shows no role of giving IV antibiotics to patients in sepsis. However, members of the ASA prefer to administer antibiotics to those patients who already are in sepsis or have some sort of infection. A randomized control trial reported no difference in catheter tip colonization when sterile gowns are worn compared with not wearing sterile gowns while performing an epidural procedure. Literature is also scarce in with respect to removal of objects from your hands and wrists, such as ring, wristwatch, and other ornaments before proceeding for central neuraxial block. Infections such as localized abscess, epidural abscess, and sepsis have been reported to occur when gown and gloves were used while maintaining all aseptic techniques. After reviewing the literature, many members of ASA preferred to wear gowns and gloves while performing spinal and epidural. However, a consensus could not be achieved whether it was necessary to use a different mask for each patient. Studies also show that there was no difference between using chlorhexidine versus pyridine solution in terms of development of infection. However, the members of ASA preferred to use chlorhexidine over pyridine. Studies also showed no difference in the efficacy of using same bottle of disinfectant for multiple patients. However, members of ASA suggested that people should ideally use a different pack for each patient. Studies also lack comparison between the use of sterile dressing compared to regular tapes. However, ASA members prefer that we should use a locked sterile dressing after insertion of epidural catheter. At many centers, it is a common practice to use sterile gowns and gloves. Anesthetists also scrub their arms using pyridine or chlorhexidine-based solutions before donning the gowns. Literature does not show very strong evidence regarding comparison of using all aseptic measures for central neuraxial block versus performing the procedure with minimal aseptic technique. However, there was not a single paper that showed that you should proceed without any aseptic measures. In certain resource-limited setups, sterile gowns and gloves increase financial burden on patients, which is why some of us prefer not to use them. With recent restrictions on importing items from abroad, there is limited supply of disposable gowns, gloves, and sterile packs. A few centers in the country have stopped using chlorhexidine due to adverse effects as observed with some batches. And instead of chlorhexidine, they've started to use pyridine. Disposable gowns and gloves also add up to the non-biodegradable waste, ultimately which adds up to the pollution. And it also contributes to global warming if this waste is incinerated. Without a clear connection between sterility and development of infection, some anesthetists in resource-limited setups prefer to perform central neuraxial block without fresh gown and gloves. However, they wash their hands using alcohol-based solutions or soap before performing such procedures. Now we'll come to line insertion, and we'll mainly talk about central lines. Venous cannulas, arterial lines, and central lines are performed by anesthesiologists all around the world. Practices of maintaining sterility differ and from one place to another, depending on how the consultants have been trained and according to the availability of resources at each center. So this is how a central line is usually inserted. So after consent, the anesthesiologist wears a mask and cap. Both the arms are scrubbed using chlorhexidine or pyridine solution. Insertion site is cleaned using pyridine. A sterile drape is used to cover the site. Ultrasound guidance is recommended nowadays. And after insertion of central line, sterile dressing is done, and the dressing is labeled with date and time. Using all aseptic measures during central line insertion takes a few minutes. And if central access is required for patients who have drastically deteriorated during a procedure, every second spent is essential. CLABSI by definition is line-associated infection or sepsis that occurs 48 hours after insertion of a central line. Literature shows that majority of the line-associated sepsis occurs much later, which is after 2 days, and handling of the central line using multi-lumen catheter is more responsible for such an event. Cleaning the hub using alcohol-based solutions is recommended. Central lines should ideally be removed as early as possible once the indication for the insertion is gone. Subclavian and internal jugular sites carry less chance of developing infection as compared to femoral access. In patients who deteriorate suddenly or require inotrope or vasopressors, or in patients who develop massive air embolism during surgery, getting an early access is often given priority over taking aseptic measures. Now, my personal opinion, keeping the topic aside, I would strongly recommend taking all aseptic measures for central line insertion as well as epidural. It's better to be safe than sorry. Anesthesiologists have been sued by patients who develop sepsis or meningitis after CVP insertion. And documentation regarding the conduct of procedure using aseptic technique is the only way out of it. So these are the references that I've used. Thank you.
So we have heard both the sides. So we have heard both the sides. As per जो हमें दिया गया है उसमें हम ऐसे करते हैं कि पहले is there any role of telemedicine in anesthesia, and then after that we'll take a question and answer session. अच्छा चलो कर लेते हैं बेटा. How many of you are in favor of pro? And how many of you are in favor against the?
Let me make a very unpopular statement that of course theoretically वो कर सकता है, negate कर सकता है that we should not be taking aseptic precautions, but practically what has happened, since we have not published, so we can't we have not documented, so publish or perish, so we can't say. But tell me, during all your training in civil hospital or all the other places, हम कितना इस पूरे बंडल को फॉलो करते हैं, और ये बंडल खुद कब आया, और उससे पहले कितने इन्फेक्शंस होते थे या नहीं होते थे. I mean, it's a very unpopular statement, and I'm sure people are getting shocked that why am I saying that. But there is something that is written in theory, and it should be practiced, and wherever possible, it should be practiced. But as he said, how many disposables are available? अभी 3 दिन पुरानी बात है that Indus Hospital was short of gloves. Gown तो बहुत दूर की बात है. Gloves were not available. So what do? Do we stop giving spinals? Do we stop giving epidurals? Or so? I don't want people to take a wrong message here, but the thing is, I think whenever, at least when you're having a pro and con, we can discuss the not to be discussed part of the subject as well. I don't know what other people.
Yeah, I mean, what you have talked about is what is happening in Karachi, practically in Pakistan.
Practically what is happening in Karachi, and practically what can be allowed to happen, and where should be the, agar hum, if there's that element of care is there, aap care se sirf glove pehan ke or without touching the needle here and there, and cleaning, drying the back with soap and water, and then sort of iodine आपने अगर लगा दी, और अब आपने अपने अच्छी तरह hand wash करके gloves पहन लिए, and if you don't touch the needle, and if you care, I think the word care is more important than following the bundle. It may be a very unpopular and may not be the best statement that I'm making for the day.
Yeah, let's say, Amin Khwaja, please.
What I think there are recommendations for the neuroaxial block to American society है, वो gown and gloves को allow, they are not recommending for those. अगर किसी ने पढ़ा है, so they are saying just aseptic technique and gloves.
Dr. Fauziya, would you like to comment on it?
लेकिन जो हमारी practice है, क्योंकि हम जो practice करते हैं, जो especially जो पाकिस्तान में है, उसमें तो we are using this one. लेकिन practically आप कराची की periphery में चले जाएं, कराची की tertiary cares में चले जाएं, you go outside Karachi, nobody is using the gown and gloves, just they are doing an aseptic technique. I'm talking about the private sector. I'm not talking about tertiary care के जो public sector के issues हैं, उसको हम discuss नहीं करते. लेकिन ये कि practically जो है everyone is using in a gloves, a septic technique for the spinals. मेरे ख्याल में nobody will disagree with me. लेकिन there जो those who has recommended not to use a gown, they have got different they have got different setups. लेकिन जो if you go to the practically theoretically, so they are not recommending for the spinals में we go for the gowns and gloves. Use an aseptic technique and the gloves. Madam, कुछ कहना है?
डॉक्टर फौजिया को दो. हाँ.
नहीं,
Yes, Dr. Fauziya, your comments.
There are always controversies about these things, and there are people who are for it and they're against it. I think what Saida has brought about is, practically तो बहुत होता है कि नहीं करते लोग, but even अच्छे centers में कई बार people take shortcuts. I think it is up to each of the hospital to decide depending upon the resources. क्योंकि हमारी resources बहुत different हैं in different areas of the same city and even in the country. तो वहाँ जहाँ evidence बहुत, क्योंकि ये evidence भी जब देखा जाता है तो उसमें कुछ evidence जो होता है वो बहुत evidence होता है और कहीं evidence जो है वो opinion based होता है. So I think one should look at the literature and then decide for yourself depending on your resources. The minimum available क्या होना चाहिए?
Yes, Dr. Saida, your comments.
नहीं, मेरे comments तो actually देखिए theoretically तो ये भी करना चाहिए वो भी करना चाहिए सब कुछ सही है, but अभी मुझे अमीन ख्वाजा बता रहे हैं कि the most recent guidelines of ASA suggest that you don't have to wear the gown. The thing is कि देखिए क्योंकि हम लोग उस पर काम नहीं किया हुआ है हमने, तो हम सिर्फ अपना experience से बोल सकते हैं and I mean nobody can take us seriously because it is just our experience. हमने लिखा क्यों नहीं? That is our shortcoming. But the thing is कि मैंने सारी जिंदगी, I mean, I have worked in pediatric anesthesia for a very, very long time. I mean, all my life of anesthesia at least. And I get most of the surgeries that you do are bread and butter surgery, and you give in a caudal epidural. And the way I used to do was turn the child, clean it with iodine, wear gloves after washing my hands. I have not had a single, I've given thousands of caudal epidurals, but when I came to Indus, the surgeon, the urologist over there insists that gowning has to be done, the draping has to be done, and this has to be done, and that has to be done. Okay, so what we zarur kar rahe hain. So 1 hour is spent on giving a caudal epidural. So
Yeah.
I don't know if that waste of time, of resources is really beneficial, or we are doing it because that's the fashion.
Private hospital में charges भी शुरू हो जाते हैं the moment the patient comes to the theater. Dr. Sadka, would you like to comment? And after that, Dr. Zahid Rao.
Actually, I'm working in trauma में, लेकिन ये depend करता है circumstances कितने हैं. अगर OR में है तो you can follow the bundle, लेकिन अगर ER में हो रहा है तो you cannot follow. इसी वजह से वहाँ पर मैंने recommend किया है कि only femoral artery करें या femoral CVP डालें. Not central line में नहीं, subclavian मना कर दिया है और वो भी मना के because position नहीं होती, availability नहीं होती, सारे equipments वगैरह नहीं मौजूद होते. So this depend on the circumstances कि कहाँ पर हो रहा है. OR में we can follow the bundle, but outside OR I think it is very difficult. In the ward या ER में बहुत मुश्किल होता है. Only ICU and OR में हो सकता है.
Thank you, Dr. Sadka. Dr. Zahid Rao, please. Your comments.
देखिए जैसे अमीन ख्वाजा ने बताया जो रिसेंट गाइडलाइन है कि उसमें से गाउनिंग जो है ना वो हटा दिया, लेकिन ग्लविंग जो वो तो मस्ट है कि ग्लव्स के बगैर तो आप कर ही नहीं सकते. तो ये ना हो कि ये टेक होम मैसेज ये लेके जाए जो हालांकि ये ग्लव्स भी नहीं पहनने हमने और हमने हमारे स्पाइनर लगा देना है, तो ग्लव्स तो मस्ट. बाकी इंस्टीट्यूशन की पॉलिसी पे डिपेंड करता है. हैंड वॉश डेफिनेटली हैंड वॉश ये भी मस्ट है, लेकिन गाउनिंग और ड्रैपिंग की बात कर रहा हूँ मैं कि गाउनिंग और ड्रैपिंग की बात है वो डिपेंड करता है इंस्टीट्यूशन की पॉलिसी के ऊपर, रिसोर्सेज हैं या नहीं है। लेकिन ये ग्लव्स ना पहनना ये मेरा ख्याल है क्रिमिनल है। ग्लव्स जरूर पहनने चाहिए और पूरा उसको वॉश करना। थैंक यू।
थैंक यू। देखिए, तो टेक होम मैसेज ये है कि अगर ओआर में है और सारे चीजें आपको अवेलेबल हैं तो प्लीज फॉलो द बंडल, और अगर नहीं है अवेलेबल तो एटलीस्ट आपको एसएपी टेक्निक के साथ आपको प्रोसीड करना है, और विदाउट टचिंग द आप स्पाइनल निडल और या आप सीवीपी लाइन डाल रहे हैं तो ये ख्याल रखें इसको। थैंक यू वेरी मच। सो विल गो टू द सेकंड टॉपिक।
हेलो, पेरिफेरी में क्या हो रहा है, किस तरह ये लोग फॉलो करते हैं? एनीबॉडी फ्रॉम पेरिफेरी?
पेरिफेरी में हम ग्लविंग पूरी करते हैं, सेप्टिक मेजर्स सब लेते हैं, गाउनिंग नहीं।
अच्छा, ठीक है। आई थिंक ओके, थैंक यू। Or next, is there any role of telemedicine in anesthesia? Our first speaker is Professor Ahmad Mujahid Barki. He's professor, is presently working as anesthetist and intensivist at PNS Shifa, Karachi. He is one of the pioneers in critical care medicine in Pakistan. So far, he has established 2 centers for critical care medicine in Rawalpindi and Karachi. He is author of 25 publications, out of which 4 are in international journals. Professor Ahmad Mujahid Barki.
Bismillahirrahmanirrahim. बहुत शुक्रिया आपका। It will be a short one, and I assure you इतनी लंबी नहीं होगी। I would be discussing about the advantages of telemedicine in anesthesia. Sequences, definition, background, something about tele-anesthesia, literature review, and then question and answer. If you only focus on the definition of telemedicine, it is the delivery of healthcare services where distance is a critical factor, and it is used by all healthcare professionals using information and communication technologies for exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evolution, and for the continued education of healthcare providers, all in the interest of advancing the health of individuals and their communities. As you all know, ये कोई new happening है नहीं. It goes back to 1970s. This practice is on, and now it has got a pivotal role, and it has established itself in radiology, pathology, and eye. It is used with the help of video cards and handheld cameras, digital stethoscopes, otoscopes. Attachments are now available, and airway examination tools are also used, which are according to the ASA standards. In anesthesia, its role is still uncertain, and there is limited literature available. But in my opinion, it can be used in pre-operative phase, intraoperative, and post-operative phase. In pre-operative phase, it helps in decreasing the need for the patient to go out from the home to travel, and it is cost-effective. It helps in rehabilitation. Rehabilitation means that smoking अगर आपने रोकनी है, तो medication की अगर adjustment है, airway assessment भी हो सकती है आजकल, और उसकी और जो आपने प्री एनेस्थीसिया असेसमेंट में जो भी nitty-gritties हैं, I think it can be done. And countries like America have facilities of high resolution video cameras and electronic stethoscopes, which make airway examination and auscultation of heart and lung sound easier. With the cost of the fuel and everything, face-to-face anesthetic consultation is not very cost effective. So if something is provided at home, I think it has got an advantage. And the most important point is that during the teleconsult, the patient are also told that they would be reviewed again on site before proceeding for operation. ऐसे नहीं होगा कि बस उधर हो गई तो it's final. On cable, yeah, on the day of admission, they will be asked to do another pre-anesthesia assessment. So how it is done? An appointment time, a patient will open an EMR-based portal and which will contain a thing to enable video with the anesthesia provider. And with the help of Bluetooth devices or other things, जो पेशेंट है वो अपना फिजियोलॉजिकल जो डेटा है वो अपलोड हो सकता है उस पोर्टल के ऊपर. And then a video consultation can be made with an anesthetist if it is feasible enough. So this is how pre-operative evolution can be done. This is an example of how an airway examination can be performed with the help of handheld cameras or video laryngoscopes. This is another example of pre-operative case. Intraoperatively, I think it can be used within the institution. अगर आपके पास इतने ज़्यादा anesthetists हैं नहीं और आपके OR जो हैं या operating room जो हैं वो अच्छे खासे हैं, तो एक तो institution के अंदर इस्तेमाल हो सकते हैं. दूसरा ये है कि in case of emergencies, अगर आपके पास कोई bomb blast आ गया, casualties आ गई, requiring emergent care और आपके पास इतने anesthetists available हैं नहीं, so I think it has got a pivotal role. And in remote areas, especially where the anesthetic help is scant, it can be easily used. This is just an example of robotic intubation. This is how tele anesthesia is used in advanced countries. The data is collected and it is transmitted, and it is available on smartphones, on laptops, on these electronic gadgets. अब तो दुनिया सोच रही है कि अगर एस्ट्रोनॉट अगर जाते हैं स्पेस पे और उनको कोई हेल्प की जरूरत है तो इट कैन आल्सो बी प्रोवाइडेड. Post operatively in intensive care unit and post anesthesia care unit by providing virtual surveillance, planning rehabilitation by recording post operative milestone and careful planning of pain management, especially in care surgery. So it has got a role post operatively also. This is something about to summarize that the need for for a patient to come to the hospital can be minimized, so it is cost effective and it is easier for the patient also. And you can virtually take the rehabilitation of a patient at home. You can ask him to quit smoking. Dietary adjustment जो है वो उसके अंदर हो सकती हैं. Medication adjustment है वो हो सकती हैं. So who can have a pre-anesthesia evolution by this means also. Intraoperatively in remote areas, in institutions, it can be used, and post-operatively recovery management, especially for pain, for fluid, and for other things, it is an effective tool. Toronto has also developed a system to provide anesthesiologists with the facility of conducting pre-anesthesia examination from a remote setup. So Canada is ahead. With the help of attending doctor, nurse, and patient, and consultation is done with the help of digital stethoscope. Airway examination is done with the help of video camera. All the history and examination findings are recorded and documented, which are again verified on the day of surgery. So it's not like it's आपकी वो होगी patient satisfaction के लिए, and to make sure that the anesthesia consultation is accurate at the day of surgery or on admission, it's again it is done. The potential use of telemedicine during intraoperative phase can also be made for teaching purposes, as described by the use of video conferencing to educate anesthesiologists in far areas to conduct ultrasound guided procedure in real time. This is how it is done. So are we ready yet? I think most of us are using smartphones. Most of us are using these technologies to some extent. It's not in place in my knowledge in Pakistan, at least in army, it's not there. But it's a high time that we should establish a pre-anesthesia setup with the use of telemedicine. That's all I have to say. Thanks a lot.
Thank you, Professor Ahmed Mujaddid Barki from PNS Shafa. Thank you once again for giving a nice talk. So let's see what Dr. Anam Mughal will talk about. So we'll welcome Dr. Anam Mughal to talk on is there any role of telemedicine in anesthesia? Please welcome Anam Mughal.
Thank you and Assalamu alaikum. I am Dr. Anam Mughal, Senior Registrar in Department of Anesthesiology, Surgical ICU and Pain Management. So my topic of discussion here is about the role of telemedicine anesthesia, and I'll be discussing about its disadvantages. So as Sir has already told about the history, telemedicine started back in 1950 with several hospital systems that shared images along with information by telephone, and with new equipments and devices, remote physicians were able to visit the patients in highly resource limited and expensive places. Telemedicine broke out its limited utility with the development of internet. As such, both the parties can enjoy several benefits, whether using telemedicine for follow-up visits, remote post-hospitalization, or school-based services, providing an alternate to in-person with access to care they might not have had across both the primary and specialty care. However, everything comes with its own price. There are certain issues of concern which need to be addressed while considering telemedicine in our community. Some significant issues are reimbursement policy, the policies related to patient privacy, diagnostic accuracy, lack of physician-patient relationship, liability and regulatory issues, and above all, the technology-related barriers. I'll be taking the help of certain articles for justification of my talk. The first of all, I'll be discussing about patient privacy. Renita Solemni, in her survey, showed that the ethical and legal issues related to the practice of telehealth or telemedicine services, these still need to be standardized and specific rules of application in order to guarantee equitable access, quality of care, professional liability, respect of patient privacy, data protection, and confidentiality. Another issue which was raised was about the liability and security issues. As we all know that it has been increasingly practiced in recent years, all the data sent electronically is subject to being intercepted, stolen, or misused in some fashion. These same requirements mandate that the data be encrypted end-to-end to protect patients' privacy. During COVID-19 pandemic, telemedicine turned into indispensable service in order to avoid contagion between the healthcare professionals and patients, involving a growing number of disciplines. But there were reasons which lended its questionability. This is one more study that highlighted the issue of storage adaptability. Yu Chen, in his study, shows prospects and challenges of telemedicine in the cloud era. In addition to telemedicine, there needs to be a combination of cloud computing for transforming healthcare delivery in a more effective and sustainable manner. It also presented numerous challenges, including how to achieve assurance, interoperability, security, and storage adaptability. One more literature indicating telemedicine and its role in plastic surgery, its implication and limitations were discussed, which found out that only 17% reported a statistically significant satisfaction compared to standard cohort face-to-face interactions, while 51% reported on adverse effects that included misdiagnosis, additional time consumption, additional training, technical and cost issues. So this showed that there is critical analysis on the benefits and risk of telemedicine. Its legal implications need to be carefully considered if it is to be practiced daily in our routine practice. A few studies shared by Joanna Iwu about barriers and policy recommendation for COVID-19 in sub-Saharan African countries. In the same light, another concern is the technology itself, specifically the accessibility and usability. Software must be easily operational and straightforward to be functional. Some clinicians get intimidated by the complex feature overload and graphical user interfaces. So this report highlighted the technological, organizational, legal, and cultural aspects which identified as the major barriers to successful implementation of telemedicine in these countries. This is the pie chart that is showing the percentages. One more important issue is the presence or access of internet to all the communities of the population. This narrative view shows that lower socioeconomic class has lesser accessibility to the broadband internet. So now the question arises here that do we have access of internet to all the socioeconomic classes? And do we have that literacy rate to make them follow the prerequisites of connectivity? Another issue addressed by Berry was about the regulatory. The major regulatory considerations which were given thought was about the informed consent of the patient, licensing of the physicians, the clinical privileges, internet prescribing, and malpractice insurance. This is one more issue which was addressed. The general population is also at risk of being overwhelmed. So this is a partnership needs to be created among the government agencies, clinicians, and researchers, and private sector organizations to rapidly test, evaluate, deploy, and pay for the two new telemedicine care models. This is the report shown by Sheetal, in which there are no universal federal standards for reimbursement of telemedicine visits or services, and each state is held responsible for addressing their own rules and approaches to this matter of monitoring funds. This is one more literature highlighting the same issue. The uncertainty about insurance coverage and reimbursement policies has historically been a major barrier to adoption, especially among physicians in private sectors. The most important and top priority issue is physician and patient relationship. The lack of direct contact between the patient and physician provider can create problems of its own regarding the diagnostic accuracy and physician-patient relationship. A study was done in which experience with the virtual assessment, both by service users and providers, were addressed. They reported, however, high satisfaction and minimal technical difficulties, but there were concerns about limited opportunities for physical examination, which we know that the field of medicine is incomplete without performing physical examination. Another report given by Nasser et al. Showed that lesser proportion of population or patient preferred telemedicine once COVID-19 pandemic was over. Considerations, teleconsultation also does not allow the doctor to perform the physical examination, so that it might feel that the doctor is not performing a thorough consultation. And using SMS or application as a reminder can also cause usage fatigue, where the patient or the doctors may stop responding to the interface at all. This is a survey. A satisfaction survey was done among the patients and medical staff for telephone-based telemedicine during hospitalization closed during COVID-19, and it showed negative views for safety and inconvenience, resulting in greater proportion of dissatisfaction among the medical staff. One more is the face-to-face encounter. There were critics about telehealth because they were worried that the telehealth may adversely affect the continuity of care, arguing that the online interactions are impersonal and dangerous in that the virtual provider does not have the benefit of complete history and physical examination to aid with the diagnosis and treatment. These are few more legal implications that argue the same. This is a
5
report-
minutes more.
Yes, this is a report that shows medication abortion through telemedicine. So encounters are, however, necessary in many circumstances in which auscultation or palpation is necessary. Telehealth should be considered as an adjuvant and best used to supplement with in-person visits. One more issue is about the misdiagnosis and data accuracy. I study investigating the accuracy of physical function measurements revealed that the internet bandwidth affects the validity and reliability for fine motor task measurements. This can result in healthcare practitioners making clinical treatment judgments and recommendations based on potentially inaccurate patient data if they were ignorant about the differences of technology. This is a survey that was done for quality improvement report showing preoperative anesthesia assessment. However, only patients who were proficient with mobile application and English language were eligible for the survey, highlighting the issue of literacy and language barrier in our setup. This warranted clinical efficacy and economy. So for the survey to be effective and for telemedicine to be effective, it requires good patient collaboration, which may include remote patient-directed assessment of temperature, BP, and pulse rate. And issues may also arise about inability to conduct physical examination, particularly airway and cardiopulmonary. Telemedicine with respect to hospital, Al-Manahil in her report highlighted that lack of knowledge on telemedicine and its benefits and lack of time to learn how to adopt the technology contributed to more training and workshops, and this resulted in increasing cost for the healthcare facility. So implementation of telemedicine can bring issues to the hospital and other healthcare facilities related to infrastructure planning and development. Now talking a little about tele-ICU and patient consideration. The tele-ICU is designed for leverage and not to replace the need for bedside clinical expertise in the diagnosis and treatment and assessment of various clinical illnesses. However, the remote and bedside team must work collaboratively to develop care processes to better monitor, prioritize, and expedite care to drive with greater efficiency and improve patient safety. Craig et al. In his report highlighted that tele-ICU physicians can also make poor care decisions, leading to medication error if they lack direct patient-related information. Moreover, the tele-ICU has no impact on care processes and outcomes when the technology is not accepted or used by the staff. That means we are so much dependent on tele-ICU staff for proper delivery of information of the patient to the tele-ICU physician. We will be viewing the patient from their perspective. These are some of the recommendations that needs to be implemented once we are going into the implementation of tele-ICU. The management unit, teamwork, collaboration, and patient care, each has to be addressed separately. Now, this is the last thing. The benefits of telemedicine, of course, it cannot be narrated. It enhances monitoring, it enhances coordination, but there are concerns such as disruption of traditional ICU practice, diffusion of responsibility, differences between postulated and actual proven benefits. So I'm very much clear about my view for telemedicine. The benefits of telemedicine have not been uniformly positive always. It has found its way in preoperative setting in anesthesia, but limitations such as patient ability to read, understand, and respond are the major factors. The traditional ways of history taking and performing physical examination have been disrupted. Transfer of knowledge is a major issue. How we are going to transfer our knowledge to the trainees. And setting up telemedicine in critical care needs a big collaboration of the paramedics and puts an additional cost of development and deployment on the hospital administration. Thank you.
Any question from the floor?
Any question or comments? तुम लोग ये पहले से तैयार क्यों नहीं रखते हो? सो रहे होते हो क्या? डॉक्टर सईदा सामने बैठी।
I mean, telemedicine is here to stay. I mean, there is no doubt about it. मगर जो patient को touch करके और जो patient से बात करके, that cannot of course be replaced. But the advantages attached with this, the access is so much more. That I think it should be. Or as far as हमारे यहाँ, is it available with the low resource क्योंकि अनम के उसमें था. I think आजकल तो मसलन इंडस का तो मोडस ऑपरेंडी ये है कि वो फोन करके बुला लेते हैं कि आप आ जाइए, आपकी ये डेट है, आपका वो डेट है. I think it's a big advantage. Telemedicine is something that is not just restricted to telephone, but of course videos and audios or वो सब theoretical issues of confidentiality and all will be there. But the physical patient doctor relationship जो है उसका तो मेरे ख्याल से कोई replacement telemedicine कभी नहीं कर पाई. बस उसके अपने advantages बहुत हैं.
Yeah, I fully agree with you, Dr. Brigadier Zahid Rao, please.
Yeah, I must congratulate both the speakers, last speakers. They have presented very well, even pro and con. Depending on the situation, just like our country, definitely future is the telemedicine. But there are lot many limitations to be carried out with telemedicine. Yes, partially we can apply in our setup. But as a fully, there are so many language barrier, internet facilities, illiteracy, and our patients. They are major barriers which can hindrance for a long time, not in future. I won't see in next say 10 years it will be implemented into space. But definitely future is with telemedicine. There are so many benefits. So I think both are right in the way. Thank you.
Dr. Saleh, would you like to comment? आप कर रहे हैं? Anyone wants to talk?
अस्सलाम वालेकुम, डॉक्टर तारिक कंपनी शफा. मुझे कलाम इकबाल का शेर याद आ रहा है कि आईने नौ से डरना, अहदे कहम करना, मंजिल यही कठिन है कौमों की जिंदगी में. मकसद कहने का ये है कि it is a new thing. I don't think it's a very new thing, but it's a new thing telemedicine. As far as the history taking and other the madam told regarding the monitoring testing, that is possible. But as far as the examinations, I mean, definitely examination जब तक नहीं आएंगे रैप को या पेशेंट के साथ करने उसके लिए तो आपको डेफिनेटली लेकिन बाकी चीजें जो है ना, जैसे उसकी आप टेस्ट देखने हैं या उसकी हिस्ट्री लेनी है या बाकी चीजें दे आर पॉसिबल. या अगर आपका कोई वहाँ पे रहता है आपको आप उसको गाइड करके कैसे है वो, तो भी इसको समहाउ जहाँ पे डॉक्टर या एनेस्थेटिस्ट की जगह वहाँ पे इसको अच्छी तरह इम्प्लाई कर, जैसे फार फ्लंग एरियाज वहाँ भी सर्वे वहाँ भी आप इसको गाइड कर सकते हैं. दूसरा ये कि वीडियो अगर आप उनके पास अवेलेबल है गाइड कर सकते हैं. मेरा ख्याल में ये दोनों चीजें इसको करना चाहिए. वैसे जैसे शुरू में किसी को मोबाइल यूज करना नहीं आता था, फिर वो आ गया, फिर ऐसे आप इतने ज्यादा डिपेंडेंट हो, हर चीज आप वहीं से, इसलिए मैं
मतलब what I think is that अगर कोई पेशेंट इलेक्टिव केसेस है, सर्जरी होनी है और he or she is unable to visit your clinic, तो ये हो सकता है कि मिसाल के तौर पे एक लैब कोली होनी है, तो you can take a history on telephone and then you can advise some investigations, and with those investigations she will come to your clinic later on, and then you could do the physical and general examination and physical examination and proceed accordingly. तो ये हो सकता है कि मतलब अभी इतना तो एडवांटेज हमें मिल रहा है कि एटलीस्ट हम टेलीफोन पे बात कर सकते हैं और हम कुछ एडवाइस कर सकते हैं अकॉर्डिंग टू हिज और हर कोमॉर्बिड्स. And then when she comes with all those investigations, then we can examine the patient and then we can assess कि कहाँ किस स्टेज पे वो पेशेंट है और हम वो सर्जरी प्रोसीड कर सकते हैं या नहीं, या किसी और मजीद एडवाइस की या रेफरल की जरूरत है.
एक विजिट कम हो सकता है उसका, तो फर्स्ट टाइम आप उसको गाइड कर सकते हैं.
हाँ, फर्स्ट टाइम ये है कि आप टेलीफोन पे बात कर ले. So you all agree with that कि that telemedicine should be there in anesthesia? Thank you. So we are closing the session.
I'd like to invite the chairperson, Dr. Nurul Haq and Dr. Niket Abbas to distribute the certificates. Dr. Rabia Iqtidar, please come on the stage and collect your certificate. वहीं रख दीजिए. Dr. Akbar Mistry. Next, we have Dr. Ahmed Mujadad Burki. Dr. Anam Mughal. Dr. Sadaf Khan. Dr. Rabila Hashmi. Now I will call Dr. Rafia Tabassum on the stage to distribute certificates to our chairperson. She is professor and chairperson, Department of Anesthesiology, SICU and Pain Center, Pumps Nawabshah. Professor Nurul Haq. Professor Nigat Abbas. Thank you. Assalamu alaikum. My name is Dr. Nalini. I'm resident year 1 from Asian Institute of Urology and Transplantation.
Assalamu alaikum, everybody. My name is Dr. Ali Haider. I'm a R2 resident from Sindh Institute of Urology and Transplantation.
We welcome you all to Residence Free Paper Contest. Now I would like to invite our honorable chairs for this session to come on stage. May I invite please Dr. Kashif Anwar. He is the HOD of Anesthesia and Intensive Care at Peshawar Institute of Cardiology. He is a fellow of College of Anesthetist Ireland and president of PSA KPK. He is also the author of a handbook of cardiac anesthesia.
I'd also like to request Dr. Ahmed Somro to come up on stage. He is Associate Professor, plus Head of Department and Chairman of Department of Anesthesia, plus Intensive Care at Chanta Medical College, Shahid Mohtarma Benazir Bhutto Medical University, Barkana. We would like you guys, sir, to please take over the proceedings, and hopefully we'll have a good session.
Assalamu alaikum. Thank you for giving me the honor to be chairperson of this session. It's a free paper session. We have a jury for this free paper session, which consists of Professor Sarek Khashali, Pro Vice Chairman PUHMS, former Registrar PUMHS, and HOD Anesthesia and Critical Care. The second one is Professor Mujahidul Islam from RMI. He's a professor of anesthesia and head of department at Rahman Medical Institute. Currently, Dr. Mujahid is a supervisor of CPSP in the field of anesthesiology and cardiothoracic anesthesia. Dr. Mujahid area of expertise include cardiothoracic anesthesia with focus on critical care. And our third jurist is Dr. Mohsen Nazir from AKUH. He's a consultant, Department of Anesthesia, Aga Khan University Hospital. He is currently serving as a director of Anesthesia Research Cell, member of Institutional Research Committee, and former member of Institutional Ethic Review Committee. His special theme of research is perioperative effect of smoking, sepsis and respiratory failure, post-operative pain, neurocognitive effect of anesthesia, and NORA services. He has recently served as a site PI on an international multi-center collaborative trial, POST-3 trial, which has been published in the High Impact Anesthesia Journal.
अस्सलाम वालेकुम दिल थाम के बैठे कि अब आइए रेजिडेंट्स की बारी आफ्टर सीनियर्स प्रेजेंटेशन और सबको पता है कि इट्स अ वेरी स्ट्रेसफुल सेशन फॉर रेजिडेंट बट रिवार्डिंग सेशन एट द एंड वी हैव अ गोल्ड मेडल सो आवर फर्स्ट प्रेजेंटर इज हुबा अहमद फ्रॉम CHK. The topic of presentation is identification of factors and outcome of obstetric patient surgical intensive care unit. Is it 10 minutes time, 7 for presentation and 3 minutes for question answer. Dr. Huba Ahmed.
Assalamu alaikum everyone. My name is Huba Ahmed and I'm from Dow University of Health Sciences, Civil Hospital, Karachi. I'm here to present a study in which we identified the factors and outcomes of obstetric patients who were getting admitted into the surgical intensive care unit of our hospital. So pregnancy, as you all know, is a physiological condition which, when associated with certain diseases, necessitates ICU admission. These young, healthy individuals exhibit rapid worsening of their pre-existing comorbidity or develop major complications, which pose challenges for both obstetricians and intensivists. These critically ill obstetric patients who are otherwise healthy require prompt recognition of their disease and early treatment for their better management. This cohort of patients is different in their management, not only because of their physiological conditions, but also the well-being of their fetuses are of concern. In order to provide them with specialized care and reduce their morbidity and mortality, high dependency units and ICUs should be established. So our objective was to identify the factors that led to their admission in the ICU and their outcomes, As we receive population from all over Balochistan and Sindh, we needed to have an idea of the burden of diseases that we were dealing with so that our resources could be planned according to ameliorate their mortality and morbidity. And statistics would definitely have played a very important role in directing our resources towards that. So we planned an prospective observational study in which the sampling technique was non-probability consecutive type. The data was collected from the surgical ICU of Department of Anesthesiology, Surgical ICU and Pain Management, Civil Hospital, Karachi. The data was collected over a time span of 6 months from June to December 2022. We had a sample size of 138 patients. All the patients who were aged between 18 to 45 years and were peripartum, that were NT or postpartum, were included, while all those obstetric patients who were admitted due to some non-obstetric causes like RTAs, medical diseases, or general surgery were excluded. After the approval by the Ethical Review Board and written consent from the next of kin of patients, our patients were included in the study, and the primary obstetricians and the anesthetists were thoroughly asked for the history and the reason for bringing them to ICU. This data was collected in pre-designed performers, and their outcome as being discharged back to ward or expired was also documented. So analysis was performed using SPSS version 23, and all the qualitative data was analyzed using chi-square test and was expressed in terms of mean and frequencies and percentages, while all quantitative data was analyzed using student t-test and was expressed in terms of mean and standard deviation. The effect modifiers like comorbidities, booking status, gestational age were controlled through stratification, and a p-value of less than or equals to 0.05 was considered as significant. So our results showed that the patients we received had aged between 21 to 31 years, and their gestational ages corresponded to 29 to 31 weeks of gestation. Majority of them were from urban areas, and these were from the different areas of Karachi. 68.84% of the patients were below poverty line, and majority of them were antepartum. 64.9% of the patients, that is 89 patients out of 138, had a parity of more than or equals to 2. Surprisingly, most of them were booked, but on further inquiry, we found that they were booked in setups other than Civil Hospital Karachi and were referred here only for specialized care or ICU care. 47.8% of our total population had pregnancy-induced hypertension as comorbidity. The commonest factor identified was hypertensive disorder of pregnancy, and when we further evaluated, we found that most of these patients were non-compliant with their medications. This was followed by obs hemorrhage and sepsis. When it comes to outcomes, 84.06% of the patient, that is majority of our population, got discharged from ICUs after treatment, while 15.94% patients, that is 22 out of 138, got expired. The rate of mortality was highest among obstetric hemorrhage, that was followed by sepsis. The rate of discharge was highest among hypertensive disorders. Only one patient with hypertensive disorder expired, and she expired because she developed extreme complication of intracranial hemorrhage. So parity was found to be positively associated with rate of obstetric hemorrhage and sepsis, as is shown by the p-value of 0.02. And factors leading to ICU admission were significantly associated with pregnancy-induced hypertension and parturient status as being antepartum, as shown by the p-values. When we compared the outcomes against the demographic variables, we found that most of the patients who died were unbooked, and most of the patients who got discharged had pregnancy-induced hypertension as comorbidity. Multivariate analysis was performed for controlling the effects of the confounding factors like age, gestational age, parity, residence, booking status. And we found that rate of mortality was highest amongst obs hemorrhage and sepsis. So varying maternal mortality has been reported throughout the world, from being 0% in developed countries like Australia to 40% in developing countries like India. As far as the data of Pakistan is concerned, there is a few literature available, and the last study that we found was in AKU, was published in 2016, and it had obstetric hemorrhage as the commonest cause of admission as per ours are hypertension. Most mortality was positively associated in some literature to advanced age, but we did not find any relationship. Gomber et al. And Dasgupta et al. Found primary parity was the common population in them. Ours were multiparous. Hypertensive disorders were the commonest factor leading to ICU admission worldwide as ours. Renoca's study population showed obs hemorrhage followed by hypertensive disorder as commonest causes of mortality, while in our situation, we had sepsis as the second most common cause of death. So we conclude that hypertensive disorder pregnancy are the commonest factor leading to ICU admission, while mortality is common among obs, hemorrhage, and sepsis. And we tend to share this data with public health services so that steps could be taken to generate awareness among the obstetricians and obstetric population for better antenatal care and compliance with medications. As this data was only collected from the surgical ICU of our setup, it could not be the representative of all term participants. These are my references. Thank you.
Any question from audience?
The question is that your sampling technique was consecutive. I think.
Sampling technique was non-probability consecutive.
Why?
Because non-probability sampling is when that researcher identifies that this population will be included in my study. And most of the literature that we found worldwide was based on this type of study, when outcomes and where outcomes and the factors that were leading to death were identified due to the same pattern.
Non-probability consecutive sampling will include every patient.
All the patients in my sample size is not
obstetric patient that comes to your
all
setup.
obstetric patients till my sample size is not completed is the consecutive type of
Okay, so what was the filter that identified that the patient is an ICU candidate?
This was the decision of the primary anesthetist who was bringing the patient to the ICU. We were just identifying.
Was there any criteria? Was there any criteria?
There was the only criteria was the anesthetist who operator who.
There was no definition to identify that this patient is an ICU candidate or not.
But this was not our objective. Our objective was that
How can we consider a patient an ICU candidate? That's a question.
That's not the part of our study. We were just including those patients who were coming to our ICU study.
Thank you, Uba, for your nice presentation. I have two questions. The first one is you mentioned about multivariate logistic regression. Yes. But you did not show the table of multivariate logistic.
Yes.
So where is the table?
It is not included in the presentation. Yes.
So it is the part of result.
Yes.
And you control your confounder by
Yes.
adjusting to multivariate logistic, but the table is not there.
Yes.
Because in multivariate logistic, you show odds ratios and
Yes.
95% CIs. If they are not present, then the validity of result is not. Okay. So my other question is about the methodology. Somewhat similar to the question my colleague asked.
Yes.
So how you selected the patient, how you approach the patient for data collection, and what number of variables did you collected initially?
Okay. So all those patients who were coming to our ICUs were obstetric patients who were coming were included in consecutive manner till my sample size was not completed. There was a data collection sheet in which there were various variables like age, parity, socioeconomic status, and all the other variables like were the patient's APH with the antepartum or postpartum, and their outcomes were mentioned there, and we collected the data according to them.
Dr. Rahman, excellent presentation, and I want to know clearly what were your objectives?
Our objective was to identify the most common cause that patients were coming in our ICU with. So as we can, direct our resources and our plans for their treatment and to ameliorate their mortality and morbidity.
Thank you. Our second presenter.
Second one. Second presenter is Neeta Devi from CHK. Her topic is compare the effectiveness of dexamethasone and dexamethasone as adjuvant to provocaine on onset and duration of supraventricular nerve block. Neeta Devi, please.
I am Dr. Devi, Resident EFO in the Department of Anesthesia, Civil Hospital, Karachi.
Is I am here to present my study to compare the effects of dexmedetomidine and dexamethasone is adjoined to bupivacaine on onset and duration of supraclavicular block undergoing upper limb surgeries. The administration of the supraclavicular block is easy and safe currently by using ultrasonography for higher block success rate and with small incidence of pneumothorax as compared to blind technique. Dexmedetomidine is a potent alpha-2 adrenergic agonist and dexamethasone is a potent anti-inflammatory and anti-nociceptive effect and divide the potential side effects. Our rationale was to compare the effects of dexmedetomidine and dexamethasone as adjoined to bupivacaine on onset and duration of block who are undergoing elective upper limb surgery, and it's helpful in recommending a method to quicken the onset and extend the duration and upgrade the block in our population. Other adjuvants can use like ketamine, buprenorphine, and clonidine, which have been used with local anesthetic drugs to speed up the onset and prolong the duration and improve the quality of block. My objective of my study to compare the onset and duration of sensory and motor block by using dexmedetomidine and dexamethasone is adjoined to bupivacaine in supraclavicular brachioplexus block in patients undergoing elective upper limb surgeries of hand, wrist, forearm, and elbow. This study was conducted in orthopedic room of Civil Hospital, Karachi after the approval from review board, and it's a type of randomized controlled trial. The total duration of surgery, duration of study was 6 months, and it's a non-probability consecutive sampling. I have taken total 60 number of patients, 30 in each group. Group A contained dexamethasone 8 mg was equal to 2 ml in adjoint to bupivacaine 0.5%, approx 18 ml, and total volume is about 20 ml. And in group B, dexmedetomidine according to weight 1 microgram per kg, which is equal to 2 ml in adjoint to bupivacaine 0.5%, 18 ml. This also total volume is 20 ml. Those patients who are included in my study were having the age between 18 to 40 years, American Society of Anesthesiologists, physical status 1 and 2, and the patient undergoing elective upper limb surgeries, undergoing supraclavicular anesthesia of hand, wrist, forearm, and elbow. Those are excluded from my study are non-consenting, having neuropathy of operative limb, patient on corticosteroids for 2 weeks or more within the 6 months of operation, having hypersensitivity to study drugs, having coagulation profile deranged, and the pregnant patient. After standard pre-medication was given on the night before surgery and fasting guidelines was followed, procedure was explained to all participants in their own language, written and informed consent was taken. In the OR, the standard monitors like NIV, pulse ox, and ECG was attached. IV midazolam of 0.05 mg per kg was given to all participants before procedure. Nerve identified by the ultrasound in supraclavicular region by the implant technique, nerve stimulator applied by using 5 mm stimulating needle observed for muscle twitches of 1 Hz of intensity of 1 milliampere. After achieving a twitch, the current intensity was decreased to 0.5 milliampere, and if continuation of twitches at an intensity of less than 0.5 milliampere, a test dose of 0.5 ml of the study drug was injected. The entire volume of the study drug was injected superior and inferior to the artery after careful negative aspiration. The onset of sensory block was assessed via the pinprick sensation and motor block assessed via the modified Bromard scale, and the surgery was proceeded. Post-operatively, patient was observed in PACU and orthopedic ward for duration of sensory and motor block. Now the results were analyzed in statistical package for social sciences 19. Relevant description, statistics, percentages, and frequency was computed for qualitative variables like ASA status, diagnosis, and gender. And the mean and standard deviation for normal data or median for non-normal data was computed for quantitative variables like age, weight, height, BMI, and the onset of sensory and motor block was discussed. T-test was applied to compare the onset and duration of sensory and motor block between the two groups, and the p-value is less or equal to 0.05 was considered significant. These are the demographic variables which shows there is no statistically significant demographic differences in the p-value, which is insignificant, and there's no such difference in the gender. The main slide of my study was to compare the onset and duration of sensory and motor block. Like in group A, dexamethasone, total number of patients was taken 30. The onset of sensory block checked in minutes, like 18.91 minutes with dexamethasone, and with dexmedetomidine, it is approx 24.71 minutes. And the duration of sensory and motor block was assessed. It seems that dexamethasone taking 537 minutes, and with dexmedetomidine 743 minutes. It means that duration of dexmedetomidine group was prolonged. Regional anesthesia and orthopedic procedure superior to general anesthesia in terms of sensory and motor block lace and impression defects. For surgeries on the upper limb, the brachial plexus block is practical and supraclavicular approach is preferred. Is the neurosed part of the plexus located there, and anesthesia will be rapid, dense, and predictable for the entire upper limb. In our study, we aim to compare the effects of dexmedetomidine and dexamethasone agent to bupivacaine on onset and duration of motor and sensory block. Our study showed the same results like MS et al. Revealed that the mean duration of sensory and motor block was significantly prolonged in dexmedetomidine group as compared to dexamethasone, and the onset of motor and sensory block was shorter in dexamethasone than dexmedetomidine. Gunnison et al. After the axillary block with dexmedetomidine and dexamethasone agent to bupivacaine, they compared the duration of sensory and motor block. They found that the duration of sensory and motor blockade was significantly more with dexmedetomidine group. And the study was shown, the Kithoria et al. Concluded that the supraclavicular brachial plexus block addition to dexmedetomidine as agent shortens the motor and sensory onset time and prolongs both sensory and motor blockade. Our strength of my study was using ultrasound, so drug administered perineurally, so nerve integrity maintained and minimize the patients from complications. Another study strength is peripheral nerve stimulator we use in our study, so nerve injury, discomfort, higher failure rates was avoided. Limitations: use of only fixed dose of dexamethasone 8 mg as compared to dexmedetomidine 1 microgram per kg. Fixed rescue analgesia and patient satisfaction was not seen. Only orthopedic surgeries were included. In conclusion, the addition of dexmedetomidine to bupivacaine prolonged the duration of block than dexamethasone, but the onset of block was shorter with dexamethasone when added to bupivacaine. These are my references. Thank you. Thank you so much.
क्वेश्चन आंसर। पहला तो मेरा क्वेश्चन है कि डेक्सामेटामेटाइन तो एक ही कंपनी ने पाकिस्तान में लॉन्च किया हुआ है और पब्लिक सेक्टर हॉस्पिटल में डेक्सा डिफरेंट कंपनीज की अवेलेबल होती हैं, तो आपने किसी एक को फोकस किया था? नहीं, पिसिडेक्स तो एक ही है ना, ब्रूक्स कंपनी की तरफ से सब पे पूरे कंट्री में, लेकिन डेक्सा की बात कर रहा हूँ, डेक्सामेथाजोन तो किसी दूसरी कंपनीज की थी या एक ही कंपनी की? माइट बी अ क्वालिटी इज डिफरेंट.
Only one.
Okay. Question from audience.
Thank you very much, Nita. Very good presentation. Tell me, what is the most important step in the method of randomized control trial?
I am considering my study through taking the randomly allocated patients. Like I am not like specifically doing, like I am only taking my patients which are undergoing the elective upper limb surgeries.
Okay. The prime thing in randomized control trial is the randomization.
Randomization, yeah.
So did you mention how you randomize your interventions?
Yes, I am mentioned.
So which method you used?
I am only randomly allocated the patients who are undergoing elective upper limb surgeries.
There is random allocation, but randomization is a different thing, which is a prime thing, a prime process called randomized control trial. So did you use any method, any specific method for randomization?
No, computer setted method like.
How you distributed it in two groups?
What?
Which patient will be in group dexamethasone and which patient will be in dexmedetomidine? How you separated or included in two groups?
In two groups, like I am taking the elective upper limb surgeries, like in orthopedic ward, orthopedic ER. Total patients were coming, like I have daily like 2 patients. So I am using dexamethasone in one group and dexmedetomidine in another group. Like that, I am taking my data.
On your own, that whom to use. It's your choice that
Yeah.
you are going to use.
Okay, thank you. Question है वहाँ पे? भाई को दो दे.
You mentioned that dexmedetomidine and dexamethasone as adjuvants to anesthesia. Okay, then I have a question that these are adjuvants. So which type of analgesia have been given to these patients? That analgesia might have some impact on both the drugs?
I am assessing the onset of sensory and motor block.
What is adjuvant? I don't know.
Like if something is aided in a major drug, like I am aiding in a bupivacaine, right? So it made the drug efficacy more. It makes the denser block, and the use of bupivacaine is shorter than like simple if we are using plain.
Acha, why modified Domini scale is used to assess the, because we usually study it in the intrathecal administration of drugs, that modified Domini scale is used to assess the quantity of.
Okay, sorry, time is over. तो आप ये इनका बाद में आंसर कर दीजिएगा. Our third presenter is Mahabatul from Trauma Center, Karachi. And the topic of presentation is compare the analgesic efficacy of dexamethasone and fentanyl as an adjuvant to bupivacaine for lower limb surgery. Dr. Mahabatul.
Assalamu alaikum. I am Dr. Mahabatul, resident of anesthesia from SNDB Institute for Trauma, Karachi, and I am here to present my paper entitled as Comparison of the Analgesic Efficacy of Dexamethasone and Fentanyl as an Adjuvant to Bupivacaine in Spinal Anesthesia for Lower Limb Surgeries. So you all know that lower limb surgeries are associated with higher intensity of post-operative pain element, which is of great concern to anesthesiologists. So therefore, most of these surgeries are held under spinal anesthesia, as it provides better potential benefits in terms of especially post-operative analgesia. Other adjuvants like opioids, benzodiazepines, and alpha agonists are also used to increase the quality of spinal anesthesia. My aim of study was to compare the effect of dexamethasone versus fentanyl as an adjuvant to the bupivacaine intrathecally in patients who were undergoing lower limb surgeries. So to compare the analgesic effectiveness of dexamethasone and fentanyl as an adjuvant to hyperbaric 0.5% bupivacaine in spinal anesthesia for patients who were undergoing elective lower limb surgery was the objective to my study. And the hypothesis was the post-operative analgesia is better in the patients who received intrathecal dexamethasone with the bupivacaine versus fentanyl with the bupivacaine in subarachnoid block for elective lower limb surgeries. So it was a randomized controlled trial conducted in the Department of Anesthesia, SNDB Institute of Trauma, Karachi, in the duration of 6 months from 15 July 2020 to 15 February 2021. Total 52 patients who were scheduled for elective lower limb surgery were selected. And the
Stop.
techniques.
Standing at the back of the room, please sit down and listen to these young, please.
Aged between 20 to 60 years with the ASC classification of less than or equal to 2 and BMI of less than 30 were included in my study, while those who were not even giving the consent for this procedure and were having any contraindication to spinal anesthesia, also who were having the allergic history with the applied drug were excluded out of the study. Well, after the approval from Hospital Ethical Review Committee and CPSP, 52 patients who were scheduled for the elective lower limb surgery were randomly divided on computer-generated random numbers between the two groups, that is group BD and group BF. Informed consent was taken in the preoperative area, and there they were described briefly about the procedure. Then they were taken to the OR, where standard monitors were applied, that is NIVP, ECG, pulse oximetry. Initial vitals were taken. All the patients were given injection ringers lactate as preloading, 10 to 15 ml per kg. After that, group BD received injection dexamethasone 10 mics with 12.5 mg of 0.5% hyperbaric bupivacaine, while the fentanyl group received 25 mics fentanyl with 12.5 mg of 0.5% hyperbaric bupivacaine. None of the patient was aware of the allocation used. Pain intensity was assessed by visual analog score at the time of recovery and at the 12th hour postoperatively. Time to receive first rescue analgesia in these postoperative hours was noted as a VIA score of greater than 4. The drug used for the rescue analgesia was IV tramadol 50 mg, and time to achieve sensory onset was also noted. For statistical analysis, SPSS 24 version was used. Standard deviation and mean were calculated for quantitative variables, while t-test was used to compare the means between the two groups, and the p-value of less than 0.05 was considered significant. Now coming with the result, first chart is showing the demographic data, and as you can see, there were no significant differences between the two groups. Okay, this is showing the comparison of the time of onset of the block and time to receive first rescue analgesia. This is a graphical representation of my outcome. As you can see, the time to achieve sensory onset was showing no significant differences between both the groups, while time to receive first rescue analgesia, when compared the dexmedetomidine with fentanyl, showed that the dexmedetomidine had 426.58 plus minus 92.44 minutes to receive the first rescue analgesia, while the fentanyl group required 206.44 plus minus 48.47 minutes, which is showing the great significance as p-value came out to be less than 0.0001. This chart is showing the comparison of the adverse effect between the two group. Parameters involved were headache, nausea, hypotension, bradycardia, and sedation. None of these parameters showed any significant differences between the two groups. Well, my study suggests that both fentanyl and dexmedetomidine can be used safely as an adjuvant to the intrathecal bupivacaine for spinal anesthesia. However, dexmedetomidine at the dose of 10 mics can use to increase the duration of block and decrease the time of requirement of rescue analgesia. There are further studies which support my result, but I will talk about only few. As Gupta et al. Reported that increasing the dose of dexmedetomidine from 2.5 to 10 mics will increase the sensory and motor blockage. Also, it has the side effect of hemodynamic variation, that is decreased heart rate and decreased blood pressure. But in my study, this effect was negligible. And Remila et al. Also noted the same result. Like every study, I have some limitations too, as I have considered healthy adult ASA1 and ASA2 patients. So you all know that comorbidities do have direct effects on the pharmacokinetics or the other drugs. So definitely results would be different. And I suggest that further studies should be carried out in order to check the superiority of dexmedetomidine as compared to other standard adjuvants to spinal anesthesia. So here I conclude the study that dexmedetomidine with the combination of bupivacaine intrathecally depicts the effectiveness regarding time to the first rescue analgesia when compared to fentanyl. But in terms of time of onset of the block, there is no significant difference between the two groups. Here are the references of my study, and thank you for your kind cooperation and listening.
Question answer.
Good presentation. How you calculated your sample size?
It was basically randomly select the patient on computer generated basis.
Sample size.
Sample size in a randomly, I selected the randomly patient. I select myself was a non-probability consecutive sampling, so I selected myself.
52 was to.
On computer basis, I selected first 26 in the dexmedetomidine group, then last 26.
How will you justify your title of study, like objectives to compare the energy and efficacy of dexmedetomidine and fentanyl as an adjuvant to bupivacaine for lower limb surgery? However, fentanyl is itself an analgesic. How can you justify it?
No, I did not use it as analgesic. I use it as additive to the analgesic. I use it as additive to the bupivacaine intrathecally to increase the duration of block and to decrease the rescue analgesia requirement. I use it as an adjuvant, not as an analgesic purely.
By adjuvant, what do you mean by adjuvant?
Adjuvant and additive.
Analgesic.
Sorry?
It's purely analgesic.
No, not rescue analgesic.
I'm not saying rescue, it's analgesic. Fentanyl is analgesic. And you are using it in this your study as an adjuvant.
As an additive to the another analgesic agent to increase the efficacy of that another agent. I used it in that term.
So what is the clinical significance of your study?
Sorry?
What is the clinical significance? What impact your study will have in the literature?
Well, other adjuvants do have so many severe side effects, like in opioids, you can see pruritus, nausea, vomiting, hypertension, which have been reported in so many case reports, so many previous literature. When I studied literature about the dexmedetomidine, especially international literature, which is full of the dexmedetomidine use, and they are coming with a good result. So I thought that in our setup, like in Asia, these studies have not been done regarding dexmedetomidine, that is alpha-2 agonist, and it has not much side effect in comparison to the other adjuvants.
So what about bradycardia and hypertension in dexmedetomidine?
The effect was not very negligible. This type of effect was very negligible. I did not count it as the significant result. Both groups showed some side effect, but they were not significant.
Thank you.
Thank you. Our next presenter. Thank you very much. Our next presenter is Dr. Zainab Afzal from FRPMC. The topic of presentation is comparison of prophylactic use of ketamine and dexmedetomidine for prevention of shivering after spinal anesthesia. Dr. Zainab Afzal.
Good afternoon, ladies and gentlemen. It is both an honor and a privilege to present an article for the brief paper competition at the PSA 41st Annual Conference. I'm Dr. Jennifer Pataya from Medical College, and I'm presenting the study on comparison of prophylactic use of ketamine and dexmedetomidine for the prevention of shivering after spinal anesthesia. So I cannot view the presentation. Each and every one of us in this room has likely dealt with patients that have had shivering after spinal anesthesia. It is one of the most problematic and troublesome things that a patient faces intraoperatively after spinal anesthesia, the etiology of which is not understood sufficiently. There are many drugs used for the prevention as well as for the treatment of shivering intraoperatively, such as meperidine, ketamine, fentanyl, morphine, but many of us have not utilized dexmedetomidine for this purpose. Also, there is more research conducted on ketamine as compared to dexmedetomidine in our local population. Hence, the aim of this study was to compare the efficacy of intravenous dexmed with that of ketamine for prophylactic use in the prevention of shivering following spinal anesthesia in patients undergoing lower abdominal or lower limb surgeries. The hypothesis was there's a difference in efficacy of prophylactic ketamine as compared to dexmed for prevention of shivering after spinal anesthesia. This was an RCT randomized controlled trial that was conducted in the Department of Anesthesia, Combined Military Hospital, Peshawar from 1st August 2020 till 31st January 2021 for a period of 6 months. After getting the permission from the ethical committee, the sample size was calculated using WHO sample size calculator. The power of the study was aimed at 80% and confidence interval was taken as 95%. And taking into consideration the results of a previous study by Anita, the expected efficacy of ketamine 54 as compared to 76 with dexmed for prevention of shivering after spinal anesthesia. So the sample size came out to be 146. The technique that was used was non-probability consecutive sampling technique. The patients were randomly allocated into 2 groups, with 73 patients belonging to the group A, which was the ketamine group, and 73 patients belonging to group B, which was the dexmed group. Patients that were ASA classified 1 and 2, aged 20 to 50 years of either gender that were scheduled for lower limb and lower abdominal surgeries were included. Those that had thyroid or neuromuscular diseases, pregnant females, patients on narcotic sedatives, patients that required blood transfusion intraoperatively, patients with an initial core body temperature greater than 38 or less than 36, or patients that had known allergy to the study drugs were excluded. The randomization was performed by the anesthesia assistant who was not involved in the study. Patients meeting the inclusion criteria were selected and randomly placed into 2 groups, 73 each, in a 1:1 allocation ratio via the lottery method. The anesthesia assistant randomly chose the concealed opaque envelopes to determine the assigned group, prepared the drug, labeled it, and handed it over to the anesthetist for the administration. The study subject as well as the clinician were blinded to the group assignment, that is double blinding. The demographic information of the patients as well as the informed written consent was taken after ensuring confidentiality. Group A received injection ketamine at a dose of 0.5 mg per kg, diluted in 10 ml of normal saline and was given as an infusion over 10 minutes. Group B received injection dexmedetomidine at a dose of 0.5 mcg per kg, diluted in 10 ml of normal saline and was given as an infusion over 10 minutes. The infusion was administered just before administrating the spinal anesthesia. A spinal anesthesia was given using 2.8 ml of heavy 0.5% glutathione. The temperature, which is the core and surface, both core and surface temperature, heart rate, blood pressure, mean arterial pressure, oxygen saturation, and level of sensory block were assessed before administration of spinal anesthesia and at 5-minute interval. The ambient temperature of the OT was measured using the wall thermometer and was maintained at 24 degrees Celsius plus and minus 1 degree Celsius. All the patients were draped using a single layer of surgical drape sheet. The presence of shivering was observed after 45 minutes of the spinal anesthesia as per the operational definition. The Crossley and Mahajan scale was used to assess for the data collection and for assessment of the shivering. This is the scale. The presence of shivering was observed and graded from 0 to 4, where 0 indicated no shivering and 4 indicated shivering all over the body. The data was analyzed using the SPSS software version 22. Mean and standard deviation was used for the presentation of quantitative variables. Chi-square test was applied to compare the efficacy of both the groups. Stratification was done with regard to age, gender, ASA classification, history of smoking, initial body core temperature, and BMI to see the effect of these variables on the efficacy. Post-stratification, chi-square test was applied and the p-value of 0.05 was taken as statistically significant. The results were as follows. The mean initial core body temperature in group A was 36.965 plus and minus 0.22 degrees Celsius, while it was 36.931 plus or minus 0.21 in group B. A statistically significant difference of p-value of 0.03 was observed in group B and group A, with higher efficacy in 56 patients in group B as compared to group A. Hence, the prophylactic, it could be concluded that prophylactic use of IV dexmet was more effective than IV ketamine in preventing shivering. These are the limitations of the study. The longer duration of surgery has been associated with shivering, but in this case, the duration of surgery was not included. The conflicts of interest were none. These are the references, and thank you so much for your attention.
Dr. Zainab, nice presentation. Did you use any measures to prevent inadvertent perioperative hypothermia like warm air blankets, bed warmers, hypothermia, even space blankets?
I think the rape shield was made. That was constant for all the reasons.
Good presentation, Zainab. One thing that you mentioned, the objective of prevention of shivering among two groups. That was your objective. And your results showed the poor body temperature difference. So did you observe the prevented shivering, which was more in dexmet group as compared to other group, according to the scale you mentioned? Or you only measured as an outcome the core temperature of both? Because core temperature is different than the perception of shivering is different. And your objective is somewhat in between.
So the scale was basically used and the performer was based on the scale, and shivering of grade 1 was considered significant in patients, and for those patients, the rescue drug was given. Yes, sir? Yes, sir. The efficacy was defined as no shivering after 45 minutes of interval. So basically the efficacy was compared.
Okay. Thank you.
Dr. Anila Munawar from Multan.
Assalamu alaikum. I am Dr. Anila Munawar from Mr. Hospital, Multan. The topic I'm going to discuss here is comparison of the effect of thoracic epidural analgesia and thoracic paravertebral block on post-op analgesia duration in the patients undergoing thymectomy. Thoracic surgeries, one of the most painful surgeries, as the incision is also long, include thoracotomies and VATS. But patients who are presented with the large size thymomas, we have to undergo sternotomy for those patients. So what are the factors that cause pain in all these surgeries? There are skin incisions, intraoperative tissue retraction, dissection, cannulation, and drainage. All these factors contribute to the pain in these patients. This pain, if not being treated properly, what it can lead to? It can lead to chronic pain syndromes. It can increase the hospital stay of the patient. That might be cost effective for the patient as well as on the hospital side. And it can also lead to increased post-op morbidity. So to counter this post-op pain, we have several analgesic techniques. We have thoracic epidural, we have thoracic paravertebral block that I have discussed in this study, serratus anterior plain block, pleural block, and systemic and intrathecal analgesia as well. The main objective of my study is to compare the effect of thoracic epidural analgesia and thoracic paravertebral block in terms of VAS score, consumption of opioids, the time for first rescue analgesia, and side effects of drugs in the first 24 hours in the patients undergoing thymectomy. The study was conducted in National Hospital Multan, and we have undergone a randomized controlled trial study in a duration of 12 months. The sampling technique was the non-probability consecutive sampling. We have selected 64 patients. Sample size was calculated using OpenEpi calculator. Patients were divided into two groups, Group A and Group B, by the lottery method. Group A, we have 32 patients which will be undergone thoracic epidural analgesia. And in Group B, we also have 32 patients for thoracic paravertebral block. This is the epidural analgesia. This is how an epidural catheter is being placed in the epidural space. The next is thoracic paravertebral block. Thoracic paravertebral block is being given at the level of T4, 5, 6, and 7. We will apply this in this study. Now, all the patients will be given general anesthesia according to the hospital protocols. Epidural will be given to the Group A patients by hanging drop method, and paravertebral block to be given in the Group B patients from T4 to T7. We will give this block when surgery has been completed and the patient is just going to for dressing. After that, we have given the epidural, we have given the paravertebral. Now block will be activated and catheter will be removed immediately. Time will be noted. In this study, the primary variable and the secondary variables that we have discussed. First, in the primary variable, we have discussed using VAS scoring. We have compared the pain. And in the group, both the groups, total duration of analgesia and the time for rescue analgesia in both groups. As far as the secondary variables are concerned, we have taken these patients for hemodynamic parameters, consumption of narcotics, and side effects of drugs. This is the hemodynamic parameters of the patients we have taken. Time duration was about 24 hours. We have followed all those 64 patients for up to 24 hours. So mean arterial pressure, heart rate, SpO2, and respiratory rate, they have been shown in this figure. This is the result. Pain was measured by VAS scoring. And then both these tables were organized about how much pain control we have achieved in both groups. In thoracic epidural analgesia, as shown in the table, we have 38.3% accident pain control, while we have 47.8% good pain control in thoracic paravertebral block. The rescue analgesia, the analgesia that was first given in both groups, at which time it was given, it was earlier in the thoracic paravertebral block as compared to thoracic epidural analgesia. Patients were hemodynamically more stable in the epidural analgesia, but one thing, side effects were less as with the thoracic paravertebral, but they were not statistically significant when compared with thoracic epidural analgesia. These are my references. Thank you so much.
You removed epidural catheter immediately after inserting it.
Sorry, sir, please repeat.
When you remove epidural catheter.
So we have removed epidural catheter after when we have given the drug, and after that check the response and remove the epidural catheter.
Improperly.
So we have given this patient after the catheter. We have inserted the catheter after completion of surgery. After that, patient was extubated, followed in the post-anesthesia care unit. After block was achieved, the fact was checked, we removed the catheter.
And you gave bilateral parametric blocks.
So, sorry?
You gave bilateral parametric blocks as it was for Norton cases.
Yes, sir.
Which side is it? For parametric blocks?
Sir, at which level, T4, T5, T6, T7?
Side.
Close to the vertebral, close to the vertebral canal.
Thank you.
Welcome.
Thank you, Dr. Neela, for your presentation. We have few more questions for you.
Dr. Neela. Still, you have a time for question answer.
We have few more questions for you.
सर आप क्वेश्चन करें जब तक वो आ जाएंगे.
Yes, sir.
Hey, Dr. Neela, very good presentation. I just wanted to ask how you counsel these patients for consenting for the randomized trial, which having an invasive interventions.
So we have described the patient's sternotomy incision is from suprasternal node to the some huge incision. Pain is a lot. And if we have explained all those risks and benefits to the patients, that although there is a risk that we give epidural and paravertebral block, but there is also on the other side a huge benefit of the forceful analgesia.
So what were your refusals and what were the withdrawals from your study? Because in the invasive interventions, you must have some refusals, you must have some failures of your block, and you remove or withdraw these patients, and you should show these patients in the flow chart.
So I have not included all that in my presentation here, yes, sir. But they were present in my original study. They have.
Yes, sir. Your sample size was
12 months, sir.
Okay, our next presenter is Dr. Anam Arif from SIUT. The topic of presentation is role of dexmedetomidine in attenuation of hemodynamic response to laryngoscopy. A dose finding study, Dr. Anam Arif.
Assalamu alaikum. This is Dr. Anam from SIUT Pakistan. And the topic of study we did was the role of dexmedetomidine in attenuation of hemodynamic response to laryngoscopy, a dose finding study. The objective was to determine the effectiveness of preoperative bolus dose of dexmedetomidine 0.75 microgram per kg and 0.5 microgram per kg as an infusion and compare it with placebo in attenuation of hemodynamic response to laryngoscopy and tracheal intubation.
As we all know that stress response to direct laryngoscopy is a well-known phenomena in anesthesiology. It was first described by Reed and Brace in 1940. The stimulation of proprioceptors at the base of the tongue causes marked increase in heart rate and blood pressure just after the laryngoscopy, and which may last for 5 to 10 minutes. The consequences of this profound change in cardiovascular physiology is well tolerated by the healthy individuals. But the patient who have cardiovascular risk factors and diseases, in those patients, it could be detrimental. So we did a study for this purpose. We included 1 of 5 adult patients in our institute, that is Sindh Institute of Urology and Transplantation. It's a prospective randomized double-blind study, and the patients were divided into 3 groups. Group A was placebo, who received 20 ml normal saline solution. Group B and C received dexmedetomidine 0.5 microgram per kg and 0.7 microgram per kg, diluted in 20 ml normal saline solution, and were given over a time period of 10 minutes respectively. Patient of both sex, age 18 to 55, ASA physical status 1 and 2, Mallampati grade 1 and 2, undergoing elective non-cardiac surgery, having general anesthesia with tracheal intubation were included in this study. Whereas patient having history of difficult or failed intubation, who are anticipated difficult intubation with Mallampati grade 3 and 4, having body mass index more than 35, having a history of hypertension, cardiovascular, CNS disorders, hepatic, renal, endocrine dysfunction, and pregnant and lactating mother were also excluded from this study. The patient was taken on the OR table, and the vitals and sedation score were recorded at 0, 1, 3, 5, and 10 minutes during this infusion. And once the infusion was ended, the patient was given general anesthesia using a protocol, using drugs, injection nalbuphine, propofol, atracurium, after checking a back mask ventilation, kept on isoflurane and 100% oxygen. Then the patient was intubated, and the time of intubation was kept less than 15 seconds. It was done by one of the 3 senior anesthesiologists at our setup. All the patients who took more than 15 seconds or second try or the use of bougie was excluded from this study. Hemodynamic monitoring was then continued for 1, 3, 5, and 10 minutes. All the data were entered and analyzed in SPSS version 20.0. Mean and standard deviation were computed for continuous variables. Categorical variables such as sedation score were presented by frequencies and percentages, and their proportion differences was compared using chi-square independent test. P-value of less than 0.05 was considered as significant. The results we found that all 3 groups were comparable in patients' characteristics with respect to age, gender, ASA status, Mallampati score, weight, and duration of laryngoscopy. The sedation score was statistically significant in group C from 1 minute onwards as compared to group A, whereas in group B, it was significant from group A only at the end of infusion. We found that no patient developed desaturation or respiratory depression at any time interval in any of the group. Statistically, there was no difference in baseline heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure. Once we started the dexmedetomidine infusion, heart rate gradually come down in group B and C, that is 7.73% and 10.6% respectively. But there was no incidence of bradycardia or use of atropine in any of the groups was noted. During laryngoscopy and tracheal intubation, maximum stress response was evident at 1 minute after laryngoscopy in all the 3 groups. 1 minute after laryngoscopy, the mean heart rate increase in group A was 38 beats per minute, group B was 20.3 beats per minute, and group C was 10.3 beats per minute. The systolic blood pressure rise was 35.23%, 26.93%, and 15% in group A, B, and C respectively. Similarly, the diastolic blood pressure rise of 1 minute post laryngoscopy and tracheal intubation was 17.3%, 13.98%, and 9%. And the mean arterial pressure rise was 23.87%, 18.77%, and 11.72% in group A, B, and C respectively. Although there was a reduction in systolic, diastolic, and mean arterial pressure, but we did not observe the phenomena of transient increase in heart rate and MAP, which was studied in various other studies. The reason of this could be because we use low dose, slow infusion rate, and a population of normotensive individuals. There was another study by Gulrani et al. In which he compared dexmedetomidine infusion 0.5 microgram per kg, 1 microgram per kg, and lignocaine 1.5 microgram per kg, and found that 0.5 microgram per kg was not very significant than the rest two groups. We also in our study found the same, that dexmedetomidine 0.75 microgram per kg was more effective. Another study by Silveraj et al. Who compared dexmedetomidine significant in reduction of heart rate, systolic blood pressure, diastolic blood pressure, and MAP, whereas asmolol was effective in attenuating the response of heart rate, systolic blood pressure, and MAP, but does not reduces diastolic blood pressure effectively. But in our study, we found that diastolic blood pressure was better controlled. So we concluded that dexmedetomidine, when given pre-operatively in a dose of 0.75 microgram per kg, obtended the hemodynamic response to laryngoscopy and tracheal intubation satisfactorily without causing any side effects, whereas 0.5 microgram per kg was only partially obtended this hemodynamic response. Our limitation is that we did this study in a normotensive individual, and if we would have done it in a hypertensive patient, it can infer valuable evidence. These are my references. Thank you.
Dr. Anand, can you show your results in the table of your results? There is no significance, but in your conclusion, there is a significance of
Sir, I couldn't hear you, sorry.
Is there any significance in this table? Statistical significance in three groups?
So we found that almost all the patients in all the three groups were comparable, like they are having same AS status, myelopathy, and everything. But all the data we included were comparable. There was no vast differences in it in all the three groups regarding the AS status, myelopathy, age, gender, and all this.
And after giving dexmedetomidine, after how much time you intubated the patient?
Sir, we started the infusion at 0 minutes and then given over a time period of 10 minutes. And just after that, we intubated the patient and then monitored again for 10 minutes.
Understand your methodology. What was the intubating conditions? Did you use any twitch monitor, train of 4 or something before laryngoscopy? Or you just saw the time after giving the trachelium dose and then intubated?
So we just checked the time. We don't have the strain of 4 in our setup. So we just checked the time and the variables like heart rate, systolic blood pressure, the non-invasive monitoring, and then we intubated the patient.
You think there might be some effect of different type of drug, different temperature of drug, different company?
So we kept it constant because I have shown it that we have given a constant formulation of drugs, like the nalbuphine was 0.15 mg per kg, propofol was 2.5 mg per kg, and atracurium was 0.6 mg per kg, and it was given for all the patients. So we kept it constant so that there is not a major difference. Plus, the drugs coming to our setup is usually of a similar company and kept at a similar, cold storage area. So it was kept constant.
So one more comment about this, such type of study which showing the hemodynamics of different interventions. If you found statistical significance in the heart rate or systolic or diastolic pressure, it may not be clinically significant. Okay, because if there is a change of heart rate of 5 beats per minute or 6 beats per minute, but with the respect to the sample size, the difference is significant statistically, but 5 beats per minute heart rate is not statistically, not clinically significant. And the similar, if a systolic blood pressure of change of 5 millimeters of mercury or diastolic blood pressure change of 5 millimeters of mercury may be statistically significant, but may not be clinically significant.
Much. The time is up. Thank you, Adam. Thanks. The next presentation is from Dr. Mariam Riaz, and CH Multan. Comparison of ketamine versus dexamethasone as adjuvant to 0.25% bupivacaine in type 2 block on post-operative analgesia duration in patient undergoing breast surgery. Mariam Riaz.
Thank you for giving me a chance to present my topic. I am Dr. Mariam Rayas from Anesthesia Department, National Hospital, Multan. The topic of my discussion, though not a very complex one, a very simple one, but an important one. The topic is the comparison of effect of ketamine versus dexmedetomidine as an adjuvant to 0.25% bupivacaine in PEC2 block on post-operative analgesia duration in patients undergoing breast surgery. We all know that breast surgery is an extensive surgery, and the patients undergo a lot of pain after this breast surgery, and there are many components that contribute to that pain. So firstly, what are the PEC blocks? Pectoral nerve blocks are the newer ultrasound-guided regional anesthesia techniques that are used for the analgesia of thoracic wall. They are the interfacial injections that were developed as an alternative to the thoracic epidural, paravertebral, intercostal, and the intrapleural nerve blocks. Their indications are primarily for the analgesia purposes after surgery on the hemithorax. So there are two types of PEC blocks. One is the PEC1 block and the other is the PEC2 block or the modified PEC2 block. The PEC1 block, we all know as an overview, it anesthetizes the medial and lateral pectoral nerves, which innervate the pectoralis muscles. And it is accomplished by an injection of local anesthetic in the facial plane between the pectoralis major and minor muscles. And regarding the modified PEC2 or the PEC2 block, it is an extension of the PEC1 block. It involves a second injection lateral to the injection point of the PEC1 block between the pectoralis minor and serratus anterior muscles to block the upper intercostal nerves, often at the level of the third rib. So basically what we do is that we place the high frequency linear probe of ultrasound and we identify the second, third, and fourth ribs, and then we place our injections. The PEC2 block, it also blocks the lateral and the anterior branches of the spinal nerves, T2 to T4 spinal nerves. And it also targets the long thoracic and thoracodorsal nerves because all these nerves are also the contributing factors to the pain after the breast surgery. Now, this is the ultrasound guided technique. As we can see that in the figure 1 in the PEC1 block, the blue section that indicates the infiltration of the local anesthetic and between the two pectoralis major and minor muscles. So we identify second, third, and fourth ribs on ultrasound, and then we identify the pectoral branch of the thoracoacromial artery. And in that plane, using the in-plane technique, we infiltrate the local anesthetic between the major and minor muscles. And in the PEC2 block, as we can see, there is another second injection that is lateral to the insertion site of the first injection, and that is at the level of the third rib. So in that PEC2 block, we insert another amount of local anesthetic between the pectoralis minor and serratus anterior muscles to give extensive coverage of pain. So firstly, talking about my adjuvants and the comparison of them, ketamine is a hypnotic and analgesic, and it has these both effects. It blocks the NMD and HCN1 receptors, and its analgesic properties can be paired with those of the opioids, nociceptive or pain control properties. And talking about dexmedetomidine, it is a very potent alpha-2 adrenergic agonist, and it has 8 times greater affinity for alpha-2 receptors than clonidine. And it has broad range of qualities, as we all know, like sedative, analgesic, and anesthetic sparing without the respiratory depression. Talking about bupivacaine, potent local anesthetic with unique characteristics from the amide group, and it is offered in usually in 2 different concentrations by the pharmaceutical companies, 0.5% and 0.75%, but it can be used for analgesia purposes in concentrations from 0.06 to 5 to 0.25%. Its administration, we all know, can be by local infiltration in peripheral nerve blocks, spinal, epidural, analgesia, and for labor pain, etc. Now, talking about my study. The objective of my study was to compare the effect of ketamine versus dexmedetomidine to 0.25% bupivacaine in PEC2 block on post-operative analgesia duration in patients undergoing modified radical mastectomy. As we all know that in breast surgery, very common is modified radical mastectomy in our setups. So the null hypothesis was that there is no difference in the duration of analgesia with both adjuvants, and the alternate hypothesis says that dexmedetomidine causes increase in the duration of analgesia. Criteria of my study, the inclusion criteria, all those females who were admitted in the OPT for MRM procedure and their ages ranged between 35 to 60 years. ASA classification of 1 or 2 and BMI less than 40. Exclusion criteria, of course, all those patients who were allergic to any of the drug that was used in my study
or infection at the site of injection, history of any substance abuse, pregnancy or breastfeeding, or thoracic cage abnormalities. Now, the study type is prospective randomized controlled trial, and 106 female patients with ASA physical status 1 to 2 were selected that were scheduled to have MRM. Patients were randomly assigned into 2 groups by lottery method. Each group included 53 patients to receive the ultrasound-guided PEG-2 block. Now, one was the bupivacaine with ketamine group, and the other was the bupivacaine with dexmed group. So we gave 32 ml of solution to both the patients in both the groups, adding about 1 mg per kg ketamine dose, and total making solution of 32 ml in the ketamine group. And in the dexmedetomidine group, we gave dexmed with the dose of 1 microgram per kg, making a total of 32 ml of the solution. Adding to it, the patients were blinded. They didn't know which drug they were receiving. The block was applied before the surgery. The pre-op assessment of the patients was done before 1 day before, and all the patients were taught about the visual analog score, in which they marked their pain on a line for up to 10 centimeters. 0 means no pain, and 10 means the worst pain possible. The outcome, the primary outcome, was to study the time for the first request of analgesia after the block was applied, and the visual analog score was assessed. Assessment was done at 15 minutes, first, fourth, and sixth hour, respectively, in the post-anesthesia care unit. So I observed the patients for 6 hours in the post-anesthesia care unit. The results were that the duration of post-operative analgesia was significantly prolonged in the dexmed group as compared to the ketamine group. So it was approximately 21.6 with a standard deviation of 1.6 hours in the dexmed group, while in the ketamine group, it was 16.7 with standard deviation of 4.5 hours. Adding, there were no significant differences in the perioperative hemodynamics, oxygen saturation, or the post-operative sedation scores or side effects in any of these 2 groups. Patient satisfaction was more in the dexmed group than in the ketamine group. So adding dexmedetomidine to bupivacaine provides prolonged post-operative pain control than adding ketamine during PEG-2 block for breast cancer surgery. Thank you.
Thank you very much, Mariam, for the presentation. Just mentioned that you have done a randomized control trial, and you elaborate the process of randomization.
So the patients, all the patients who were booked for modified radical mastectomy. Every patient that was booked for modified radical mastectomy and that was included in my inclusion criteria, that fall into my inclusion criteria, that was considered for the study. And I selected 106 patients on a consecutive sampling.
This is not randomization. This is selection.
So I used the lottery method for randomization in the 2 groups.
Show your result results. You mentioned there is no difference, no significant difference in perioperative hemodynamics, post-operative sedation, or other side effects. You should also mention the table of these perioperative.
So I can provide that to you for sure.
You should show here. So, what type of side effects do you observe perioperatively, especially for dexmed?
So no side effects as such were observed in both groups. No fall in the blood pressure, oxygen saturation, or any hemodynamics was noted.
Same, the second paragraph, it was 21.6 pillars plus 1.6 hours. Then the 21.6 is gone.
21.6 is hours. 21.6 hours patient को pain relief रहा after dexmedetomidine.
16.7 now.
जी sir.
Founders post-operatively, if you see 21.6 hours, there might be some other factors, a lot of factors affecting simultaneously post-operatively. So, did you adjust it for these variables?
Sorry, please repeat the question for post-operative.
The post-operative variables like the patient age, the incision size, the total dose that is given to the patient, the perception of the pain measuring nurses or the doctors. So there are a number of factors that act as a confounder. So did you control confounder by any statistical method?
So basically, the nurses and the staffs who measured the pain, by the visual analog score. In the pre-op assessment, one day before, the patients were taught about the visual analog score. And when they were telling all the staff that was recording the data, they were unaware of all the study.
Yeah.
Thank you.
Our next presenter is Dr. Ehsan Ejaz from NICVD. The topic of presentation is selection of correctly sized endotracheal tube using ultrasound in pediatric patient undergoing cardiac surgery. Dr. Ehsan Ejaz.
Assalamu alaikum, everyone. My name is Dr. Ehsan Ejaz, and I'm a resident from Anesthesiology Department in ICVD Karachi. Okay, the topic I'll be presenting today in front of you all is selection of correctly sized endotracheal tube using ultrasound in pediatric patients undergoing cardiac surgery. All right, introduction. So incorrect endotracheal tube size leads to air leaks in cases of small or not well-sized tubes used, repeated laryngoscopy, and increased risk of airway trauma if the tubes are used, which are bigger for the trachea in cases of children especially. Difficult endotracheal intubation under general anesthesia can cause intubation failure and delays, and these can lead to unwanted and unforeseen and even fatal results, especially in children. The assessment of subglottic diameter is important for determination of ETT size in children, and ultrasound is a technique that we can use to actually evaluate the anatomy. And this anatomy can be, this ultrasound can be a helpful tool to analyze the anatomy and use the correct size tube for the kids, for the pediatric patients. Cardiac patients present with increased risk of airway anomalies mainly and poor lung compliance, and they require higher inspiratory pressures as well. Ultrasound is a portable tool that can be used in many parts of the hospital. They can use in OR. It is regularly used for A-lines and CVPs as well, and it would be recommended. It's very useful, and there's increasing evidence that ultrasonography is reducing intubation time and hence preventing prolonged hypoxia and ischemia in children as well. So the objective of my study was to determine the frequency of correctly sized endotracheal tube selection using ultrasound in pediatric patients undergoing cardiac surgery in tertiary care cardiac hospital, Karachi, which was NICVD. Operational definitions. Ultrasonography measurements. The measurements was made at the level of cricoid arch, and the air column appeared hyperechoic and created posterior equistic shadows. Unstable cardiopulmonary conditions included heart rate of less than 40 and more than 140 beats per minute, respiratory rate of 8, less than 8, or greater than 36, and saturations of less than 85%, blood pressures of systolic less than 80 or higher than 200 systolic. Continued. The correct ETT size is defined as the size which allows an audible air leak around the tube at an inspiratory airway pressure, excuse me, of 15 to 30 centimeters of water, and the head and neck were positioned in a neutral position, not very extended, but in a neutral position. The presence of an air leak was assessed by allowing the air pressure to increase slowly and until an audible air leak was heard using a stethoscope. Materials and methods. The study design was a cross-sectional study, and the setting was conducted, this research was conducted in ICVD hospital for over a period of 6 months. And the sample size was calculated using World Health Organization sample size calculator version 2.0, with having expected frequency of correctly sized endotracheal tube on ultrasound as 60%. This figure was obtained from the past research articles, 95% confidence interval and 8% margin of error, and the sample size came out to be 145. Sampling technique was non-probability observation and convenience sampling. The inclusion criteria was having both the genders included and children of ages between 1 to 8 years. And elective surgery patients were considered, and not the emergency cases who were already admitted in the hospitals. Exclusion criteria included consent refusal if the patients did not give the consent, emergency surgeries because it can actually be difficult for them to actually sustain these experimental procedures, and patients with anticipated difficult airway due to the presence of neck mass or visual or even ultrasonographic assessments. So if we found, because cardiac anomalies do present with, for example, we have cleft lip and cleft palate and many other anomalies that can be seen on the ultrasound as well. So they were excluded from the study. Okay, the data collection procedure, hospitals, ethical committee approval was taken and CPSP approval was also taken. All the patients involved in the study were informed and written consent was observed and taken from them. and the patient's information and all the data was kept securely and was accessible for the authorized personnel only. Age and gender were recorded, and ultrasonographic measurements of the transverse diameter of the cricoid cartilage level was performed using a linear probe on the middle of the interior region of the extended neck. Okay. And a continuous positive airway pressure of 10 centimeters of water was maintained during the measurement. As we can see, the linear probe was placed at a short axis and in the middle of the interior region of the neck, and the neck was extended in this case. Data collection procedure continued. Okay. All measurements were performed by the same practitioner having a 5-year, at least a 5-year experience in the working field. After finding the vocal cords, as we can see in this slide as well, linear probe was moved caudally to visualize the cricoid arch. The transverse air column diameter, as shown between the space between the two axes, as we see on this slide, it was the subglottic diameter, and this was used to determine the ETT size for the kids, the pediatric patients. Following intubation, correctly sized ETT was assessed, performing the air leak test as described earlier. To minimize the bias, this test was performed by 2 professionals, and all the collected data was recorded on a pre-designed performer, which can be provided to you upon request. Confounders were controlled and strictly following inclusion-exclusion criteria and stratification. Data was analyzed using SPSS 21 and Shapiro-Wilks 1965 was applied to check the hypothesis of normality for age, and were expressed using appropriate descriptive statistics such as mean plus standard deviation, median, and maximum and minimum. Frequency and percentages were calculated for categorical values such as gender, age group, and the correctly sized intubations. Effect modifiers like gender and age group were controlled through stratification. And post-stratification, appropriate chi-square test and Fisher exact tests were applied. The two-sided p-value was taken as less than 0.05. Okay. Age range in this study was 1 to 8 years, and the mean was around 5 years with a standard deviation of plus minus 1.9. The majority of the patients, that is 73, were between 6 to 8 years of age, as shown in the table. 62.76% of the patients were males, and 64.14 was our the correct outcome. The correctly placed intubations were 64.14, and the failure or not correctly sized tubes were 35.86 according to our study. Correctly sized endotracheal tubes selection for the age group between 1 to 5 was 65.28%, and correctly sized for 6 to 8 years was 63% with a p-value of 0.76. And correctly sized ETT tube selection for males was 64.84, while for females it was 62.96, again an insignificant p-value of 0.820. Selection of correct endotracheal tube size is a crucial step for pediatric patients because incorrect size can cause harmful and may cause complications. Different physical indices, formulas that are used for prediction of endotracheal size tube these days are not very accurate. And these appropriate size, this ultrasound technique can be actually used to determine a better size for them. Readily available ultrasound devices are in.
The time is over.
Time is over.
Right.
The question answer time.
Thank you, sir.
There are a few limitations. Thank you. Conclusion.
Just want to ask, did you use cupped endotracheal tube? Or
Yes, we use cupped endotracheal tube.
So the cupped endotracheal tube, the cupped part of the tube having the diameter more than the actual tube size.
Yes.
So how you calculated the size of the tube with the measurement you did in the subglottic area by ultrasound? If the subglottic area you found 3 millimeters or 4 millimeters or something like that, and the tube is of 4 millimeters, but at the cuff area, it might be more than 4 millimeters.
Indeed. So usually the difference between cuff and non-cuff is 0.5, usually taken in our understandings as well. So in this case scenario, for example, if the subglottic diameter was 5, then a cuff tube of 4.5 was taken, and the pressure was increased slightly slowly until that air leak test was done, and air leak was observed using a stethoscope. So the tube of less than 0.5 less than the diameter itself was taken, and the air leak test was performed.
So what do you think? Why your success rate is 65%? In 60s, why it is not more than 60?
So it was actually more than 60 in the studies that I took from the abroad. I took it as a reference, and unfortunately, I did not have time to discuss that. I have it written in the discussion as well. Like there's 4 more studies reported a rate of 60, 88, 87.7, and 92.7.
My question is, what do you think? What are the limitation about the position or head wing or the extension of neck or of the ultrasound probe? What limitation do you think you had that you found a different result as compared to the standard?
Right.
If you are looking directly on the trachea, then you should have a correct measurement.
Of course. So this was a single-centered study, first of all. So the sample size was localized to just one center. Plus the age group was 1 to 8 years of age. If it had been more than 8 years, then the calcification and other factors would have come in as well as anatomical malformations in cardiac patients. They can actually play a role.
Okay, thank you very much.
Thank you.
Thank you. Our next presenter is Dr. Kiran Merchant from AKU. The topic of presentation is posterior reversible encephalopathy syndrome after inadvertent dural puncture versus sensocaine induced adverse drug reaction. Case report. Dr. Kiran.
Respected judges, fellow colleagues, Assalamu alaikum. My name is Dr. Kiran Merchant and I'm a 4th-year resident at the Aga Khan University Hospital. Today I'll be presenting a case regarding posterior reversible encephalopathy syndrome after inadvertent dural puncture versus sensocaine-induced adverse drug reaction. Here's a list of things that anesthesiologists are blamed for: delays in surgery, bleeding, global warming, Michael Jackson, and headaches. Talking about headaches, posterior reversible encephalopathy syndrome, known commonly as PRES, is an acute reversible neurotoxic syndrome. While the pathogenesis of the disorder is unclear, vasoconstriction and hypoperfusion leading to brain ischemia and vasogenic edema are implicated, most commonly in the parietal and occipital lobes. It is characterized by severe headache, acute loss of consciousness, seizures, visual disturbances, and focal neurological deficits. It is commonly associated with acute hypertension, preeclampsia, eclampsia, sepsis, and exposure to immunosuppressants. Here we report PRES in a normotensive patient. So our patient was a 29-year-old female, primi gravida. She was admitted for elective C-section under spinal anesthesia. Her preoperative vitals and BMI were within normal limits. After aseptic measures, L3-L4 interspace was palpated and locally infiltrated with 2% lignocaine. The introducer needle was placed and CSF flow was observed. So 0.5% of hyperbaric bupivacaine, 11.5 mg was injected through the introducer and adequate block was achieved. The patient remained stable throughout the surgery. But after 48 hours, she developed severe bifrontal and occipital postural headache, vomiting, dizziness, diplopia, and photophobia. She was initially being managed along the lines of post-dural puncture headache conservatively and was being planned for an epidural blood patch, provided her symptoms did not resolve after 48 hours. But then she developed generalized tonic-clonic seizures with uprolling of eyes, which were managed with benzodiazepines. Her MRI brain was done, which revealed features suggestive of PRES. With anticonvulsant therapy, neurological symptoms resolved, and she was discharged home symptom-free. This was an MRI brain, which showed patchy abnormal signals in bilateral, parietal, and occipital lobes, likely secondary to PRES. Let's discuss review of literature. So PRES was first described in 1996 by Hinchy et al. Previously, it was commonly associated with preeclampsia and eclampsia, but later on it was found that normotensive patients may also present with PRES, as in the case of our patient. In 2018, Ekar et al. Reported the first case of PRES in a pregnant patient without preeclampsia or eclampsia. Then in 2019, in another case report, Qureshi et al. Presented an atypical case of PRES in a pregnant patient without preeclampsia. And more recently, in 2022, Zhang et al. Reported a similar case of PRES. Some evidence suggests that dural puncture can also be associated with PRES. In 2011, Menai et al. Reported a case who developed PRES after dural puncture while attempting combined spinal epidural anesthesia for C-section. And then Shah et al. Reported another case of press after an inadvertent dural puncture during an emergency laparotomy while attempting thoracic epidural anesthesia. So there have been multiple reports that have directly implicated anesthesia as the cause of press. However, this evidence is anecdotal and it requires further exploration. Let's talk about sensocaine-induced adverse drug reaction. So last year in June, there were cases reported all over the city associated with use of 0.5% heavy bupivacaine, more particularly sensocaine, in the neuraxial blockade, especially spinal anesthesia. These cases were associated with symptoms including seizures, behavioral changes, severe headaches, and vomiting. All of these subsequently resolved with conservative treatment. One such case that we just discussed was reported in our hospital, after which the drug was discontinued and we switched to pivocaine. The rest of the cases were reported in other hospitals of the city. But only last month, new cases have started to report again, this time with pivocaine, mainly having severe headache, which resolved with conservative management. So neurotoxicity is a rare but serious problem. It is possibly associated with mitochondrial dysfunction, and it is difficult to distinguish because of substantial number of differential diagnoses. It involves utilization of local anesthetic that result in life-threatening adverse effect. Pregnancy has been found to increase patient sensitivity to local anesthetics, and it can present immediately or up to an hour after the local anesthetic injection. In 2022, when Mark et al. Reported a case of status epilepticus following intrathecal bupivacaine in hip surgery, and then another case was reported where patient developed generalized tonic-clonic seizures after spinal anesthesia using bupivacaine for cesarean section. So to conclude, we highlight the significance of suspecting press in obstetric cases with an inadvertent dural puncture in a normotensive patient, the critical role of neuroradiology in the confirmation of the diagnosis, and lastly, keeping in view the potential medical-legal implications in such cases, further research seems crucial, especially in our population. Thank you for listening.
Thank you very much. A good presentation. Actually, we selected your presentation for oral because of the ongoing issues of sensitivity and highlight these issues in the forum with the use of anything. So my question is that you mentioned that you diagnose press by neuroradiology, but in the area, source limited areas where facilities of neuroradiology, what are the clinical signs and symptoms that you predict a patient is developing press?
Okay, thank you for your question, Dr. Mohsen. You are right. Most of the hospitals in our city are low resource areas, and where you cannot have an option for neuroradiology, you can look deeply at the signs and symptoms of the patient. So initially, our patient presented with a postural type of headache, but later on, that's why we were suspecting that it was PDPH. But later on, it turned into an atypical type of headache, which was not postural. And then she also developed generalized tonic-clonic seizures. So the point of presenting this, I know that this is very difficult to have press in the list of diagnoses where there is a big list of diagnoses. But the whole point of presenting this case is to have these diagnoses in our minds so that in future, if we ever come across this type of case, we can think about this diagnosis as well.
So if you had the only thing that we should emphasize and all the other have the take home message is that whenever there is a change in the pattern of headache in 24 to 48 hours, if postural component eliminate completely, because only postural component is indicating us that it is a PDPH. And if there is no postural component, then you think 2 or 3 more worse outcomes, including subdural hematoma, then kernel sinus thrombosis, and the press. These are the 3 things that you should consider for if you don't have neuroradiology in your area.
Yeah. Thank you.
Thank you very much, Dr. Kiran. And now our Last presenter is Dr. Khushbu Dilawar from NICVD. A prospective comparison of ultrasound guided versus palpation method of radial artery catheter placement. Dr. Khushbu.
Thank you so much, sir. I am Dr. Khushbu Dilawar. I am FCPS resident in anesthesia department from the NICVD hospital. I am going to present the prospective study, that is the comparison of the ultrasound guided versus the palpative method for the radial artery catheter placement. Introduction, as we all know, the arterial cannulation is essential and necessary for the hemodynamic monitoring. For the invasive blood pressure monitoring, we use the arterial lines like the radial artery, brachial, femoral, posterior tibial, and the axillary artery. The other radial artery is the ideal location for the arterial cannulation insertion because most patients have the collateral blood flow and the compressibility for the hemostasis. Unfortunately, the anatomical landmark sometimes may not detect the radial artery in up to the 30% of the patient. Arterial cannula placement by the palpation method continue to pose a challenge to even the most experienced anesthetists. The repeated successful arterial cannulation attempt causing the potential complication like the arterial hemorrhage, spasm, and the hematoma. Ultrasound is increasingly being employed in vascular access. Several systemic evaluations have demonstrated the effectiveness of using the ultrasound for the arterial line placement. Some studies have compared the traditional blind palpation with the ultrasonography, have shown improved ultrasound outcomes. Although the ultrasonography guidance has been successful in the arterial axis, there is a little information available regarding the use of the ultrasound in the peripheral axis. We are not aware of any locally published prospective study that compared the placement of the radial arterial cannulas by using the palpation versus the ultrasound guidance approach. The objective of my study is to assess the effectiveness of the ultrasound guidance versus the conventional palpation method by the newly inducted anesthesia resident during the radial artery cannulation in the operating room for the patient undergoing the elective open heart surgeries. Material and method, the study was the prospective observational study conducted in Department of Anesthesia and ICU at an ICVD hospital for the periods of 6 months after the approval from the ERC. The total 140 patients included in our study, we randomly divided the 70 patients in each groups. Those patients having the age range between the 18 years to 75 years, undergoing the elective open heart surgeries and classified as 3 and 4 included in our study, while the patient undergoing the emergency surgery arterial cannula passed after the induction, INR ratio more than 1.5, previously angiography done by the radial artery access in last 7 days, and the patient on the continuous heparin infusion were excluded from the study. Data collection procedure, ethical committee approval, and the written as well as informed consent was taken from the all patients involved in the study group. We divide the patient into 2 groups on the basis of the cannulation technique. All cannulation procedures were performed by the newly inducted anesthesia resident under the supervision of the senior consultant. Every patient received the lorazepam 2 mg 1 hour prior to the surgery in the ward. Standard monitoring such as ECG, saturation, and intravenous cannula were then applied in the operating room. Allen stress was performed. Skin close to the insertion site was cleaned with chlorhexidine and infiltrated with 2% xylocaine. To preserve the wrist extension, the wrist was extended and tape on board. The radial artery was percutaneously punctured with 20-gauge Vigo needle. For the ultrasound guided radial artery cannulation technique, the radial artery was imaged in short axis and was used to place the needle. Evaluation time is basically the time from the application of the portable ultrasound to locate the radial artery till the skin punctured by the Vigo needle. While the cannulation time is the interval of the time between the first penetration of the needle through the skin to the successful cannulation of the artery. While in the conventional palpation method, the radial artery was located by using the palpation technique and the Vigo needle was guided by continuous osmotic palpation of the arterial pulse. Evaluation time is the time between the operator initial placement of fingers on the patient wrist and the needle puncture the skin. While the cannulation time is the interval of the time between the first penetration of the needle through the skin to the successful cannulation of the artery. The primary outcome of my study was a successful arterial cannulation, while the secondary outcome include the number of the attempts, duration of the screening and cannulation, and need to change the operator as well as side and frequency of the problems. Operational definition: the successful arterial cannulation surveys endpoint for both approaches. Success rate was defined as successful cannulation of radial artery in 2 attempts, while the failure rate defined as inability to cannulate successfully after the 2 attempts. Data was analyzed by the IBM FPSS version 21. Ultrasound group and cannulation palpation method were compared with the help of independent t-test, U-test for the continuous response variable, while the chi-square test, Fisher test used to compare the categorical response variable. The p-value of 0.05 was taken as the criteria for statistical significance. The results, the demographic between 2 groups were comparable as far as p-value is insignificance. While the p-value for the cannulation time in the ultrasound guided and the cannulation palpation method was significant, that is less than 0.001. Discussion: ultrasound guidance replaced the conventional palpation method in arterial cannulation because of its widespread use. Our study is among the few in the world and first in our department, which basically involved the newly inducted anesthesia residents. The result of both groups shows the ultrasound required twice time as much than palpation, less than 10% complication rate linked with the ultrasound guided cannulation that was higher than palpation approach. According to the meta-analysis by the UWJ et al., the ultrasound is preferable to the palpation approach, but our study shows the ultrasound takes the longer time and more skills to perform the cannulation. While the Betterji et al. Found no significant time difference between the ultrasound and the conventional palpation method, that is opposite to our study. While the Amar et al. Analyzed decreased amount of complication was found in the ultrasound guided radial artery cannulation, but in our study, complication rate was higher in the ultrasound guidance technique. Our study shows that the residents at the end of the day were learning the new skills in the form of ultrasound guided radial artery cannulation and more comfortable in palpating method. This is single center study due to observational nature of the study. Operator
Time is over. The question answer.
Dr. Khushbu, nice presentation. ये बताएं कि ऑपरेटर सेम था स्टडी में?
नहीं, different operators थे, लेकिन newly resident जो यूज हुए थे R1 resident.
They were used to arterial lines.
So basically इस स्टडी से पहले हमने एक वर्कशॉप हमारे इंस्टीट्यूट में कंडक्ट किया था. उसी रेजिडेंट से हमने पहले तो अल्ट्रासाउंड में आर्टिरियल कैनुलेशन अल्ट्रासाउंड गाइडेड करवाई थी, उसके बाद पैल्पेटिंग मेथड से भी करवाई थी. थैंक यू.
Thank you very much. We all appreciate all the presenters because research is entirely separate topic and is essential and important, and as well as difficult, especially in our setup where sources are limited. Despite that, residents are doing always something new and interesting. Thank you very much.
Thank you so much, sir. And a round of applause for all the people who presented over here. I know it takes a lot of courage. I'd like to request Brigadier Tariq to come up on stage, please. Thank you, sir. And present the certificates to our chairperson. Dr. Ahmed Somro. And Dr. Kashif Anwar. I'd like to request the chairpersons to please stay and hand out the certificates to our jury members. Our honorable jury, can you please come up on stage? Can you please come up on stage, Dr. Professor Saleh Khasfeli, Dr. Professor Mujahidul Islam, and Dr. Mohsen Nazir. All right. And next, like to call the poster jury to come up on stage.
I would request Dr. Sadka Aftab to please come on stage along with Dr. Anmol and Dr. Sumru. So I would request, first of all, I would request Dr. Safia to please come on stage and receive her certificate of jury. जी अभी पहले jury members को certificate है and then every resident who has presented the poster, तो आप लोग please यहाँ आ जाएं आगे, जिन जिन लोगों ने poster किए हैं आप लोगों को उसके बाद poster का certificate मिलेगा. आप लोग कोई बात नहीं. Round of applause. Dr. Amir Furqan. Is Dr. Jawdat Salim over here? Dr. Jawdat? Chale gaye? Okay. Dr. Ismat Wasim. Big round of applause for her. Can I please request the poster presenters? Okay. Huba Ahmed. Neeta Devi, followed by her. इनको भी दे दो कोई बात नहीं. It's okay. Certificate. Neeta Devi. Mahabatul. Zainab Afzal. Anila Munawar. Anam Arif. Mariam Riaz. Ehsan Ijaz. Kiran Merchant. And Khushbu Dilawar. Thank you. Thank you so much. And now I would request Dr. Amir Furkan, Dr. Safia, and Dr. Noor to please come on stage for the distribution of the certificates for posters. Alina Mahmood. Fatma Faruqi. Huba Ahmed. Rabia Kamal. Tuba Jafar. Okay. Elia Shahid. Muhammad Hassan Khan. Sidra Nazir. Sidra Tahir. Seher Khan. Wajiha Nasir. Sara Noreen. Safa Pirzada. Mahnoor Bilal. दोबारा नाम लिखो जवेरिया बख्तावर रमला शहजादा अरसलान जाहिद Arsalan here? If he's not here, can someone take it on his behalf? आप ले लें जी। आतिका सुल्तान अच्छा आप दोनों का ले लेना क्या मरियम पूरा नाम लिखना फहद इस्लाम आयशा अख्तर सदफ खान सादिया सुहेल मरियम खट्टक and Mariam from Mariam yeah. नहीं. So now I would request the please Dr. Kabir, jury members of free paper, can you please come on stage? Sir, अभी कर देते हैं. तो इनको certificate दे दीजिए. So Dr. Mohsin Nazir, please come on stage for your certificate. And Dr. Soleh Hasmeli. Sir, यही रखिए. Dr. Mohsin नहीं रुक जाए. वो खुद ही बुलाएंगे. अच्छा अब आता है.
Now I'd like our esteemed judges for the poster competition to announce the results and decide who won the third place, the second place, and who got the gold.
Bismillahirrahmanirrahim. I am here to present the results of resident free papers contest. It was a very healthy and informative contest. And as we all know, research is a very difficult as well as challenging thing. And all the presenters who were here, they dared and they presented above average. It was very difficult for all of us to decide, but we had a set criteria already given by the committee. That was, we assessed the presenter on 9 criteria and each having maximum marks of 4 and minimum of 1. That was the introduction and background of the study. That was clearly state the purpose, then objective, whether it was clearly defined or not, then methods, concise, logically organized, as well as tools validated, data storage and safety process. And 5th one was how the study was concluded. Meanwhile, the impact of that article or research work on the significance of research in current era, that was also taken in consideration. Then visual aids, and more importantly, the presentation style, and finally, the responses to the questions and comments. After considering all these, we as a jury had to select 3 top performers. So number 3rd position achieved by Dr. Kiran Merchant on case report. Though it was the case report, but it was a very important and have a very relevance to the significance of research. And it was the current problem with which we are going. That was not only because of that sensogen heavy by Brooks, but it was by the drug that is in the conclusion. So it's a future way forward for all us as anesthetists to be take in consideration. If any of patient develops such symptoms, we should be careful and we can manage that. Dr. Kiran. And then second position goes to Mr. S.N. Ejaz from NICVD. That is selection of correct size ETT for feeds, ultrasound guided. That was also very relevant, logical, as well as patients morbidity morbidity related issue and well presented, and he stood second in position. I will request Professor Saida to come on stage to deliver gold medal to the first position holder. It goes to Dr. Zainab Afzal. Dr. Zainab Afzal. Thank you very much.
So proceeding to next competition, that is a poster presentation, and the same remarks as Dr. Saleh said. Wonderful researches, 24 researches we reviewed, and 4 person comprises of this jury: Dr. Safia, Dr. Jodha Salim, Dr. Asmat Wasim, and me, Dr. Amit Khan. So we have to decide, because these 3 positions are already announced कि हम ये 3 लोगों को ही consider करेंगे. हम jury ने तो organizer को ये advise किया कि सबको दे दें, सबको price दें. तो quality इस तरह की थी, लेकिन सर ने कहा हम disclose कर चुके हैं, इसलिए हमने top 3 को लेना ही लेना है, तो इसलिए हमें वो announce करने पड़े. So the 3rd position for paper presentation is Sadia Sohail, Hamdard University. Thank you. And the second one is from Multan, Dr. Aisha Akhtar. फर्स्ट वन कहाँ से होगा? जनता क्या कहती है? बहुत जबरदस्त ये कंपटीशन था हमारा इस पे, और हम ज्यूरी को दोबारा जाके इसको रीएवैल्यूएट करना पड़ा कि हम इसको देखें कि वी हैव टू डिसाइड द फर्स्ट वन, दैट इज डॉक्टर मरियम खटक फ्रॉम AKU. Many congratulations to all presenters. Wonderful presentations. Thank you so much. Thank you, ma'am. Thank you so much.
Once again, a round of applause for all the participants. We are going to start ending our proceedings, but once again, I'd like to thank you all for your patience and for your undivided attention during this entire proceedings. Thank you so much. Yes. Yeah. Please come upstairs, madam. Can we all get a group photo session upstairs, up on the stage? No? Okay.
थोड़ी सी कुर्सियां रखवा दो खाली. Okay, so it seems we have come to the end of the 41st annual conference of PSA Karachi. What an excellent conference. My congratulations to Amin Khwaja and Asma and Zahid Rao. 3 main iske wo the. Lots of people have done a lot of hard work. We must thank Noor for his participation. Without the money, we couldn't have done anything, and he got us all the money. The scientific program was excellently made by Brigadier Zahid Akhtar Rao, and the organization was beautifully managed by Asma. Asma is a real hardworking. I see a bright light at the end of the tunnel in her form. And the timekeeping was wonderful, I think. On the whole, it was good. And I must thank the pharmaceuticals who participated in our and made this a successful event. एक खास बात जो इस कॉन्फ्रेंस की है, हमारे कॉन्फ्रेंस की, वो ये है कि दिस इज द ओनली कॉन्फ्रेंस लेफ्ट नाउ. पहले सारी कॉन्फ्रेंसेस जो थी ऑफ एनी स्पेशलिटी, दे वर organized by the doctors themselves. Today, all organizations, all sari societies hain, they take help of event managers, and event managers do it. Hamara, we manage everything ourselves, everything. This is the only society today. And you see कि कोई हमारे ऐसे कोई flaws कोई होंगे छोटे मोटे, मगर कोई बड़े फंसे नहीं हम कहीं. Everything went smoothly. The audio visual and the excellent. I think excellent. We should give a hand to the organizers. अच्छा, एक हमारी रिवायत है कि at the end of the conference we kind of invite all the outgoing cabinet and get their views, and then introduce the upcoming cabinet for the year 2023-2024. So this pleasant duty has been handed over to me today. ये हमेशा से टीपू साहब करते आए हैं और इंशाल्लाह आगे भी वही करेंगे. Today he is not in town, and that's why I'm doing it. I'm representing him really over here. So I would first invite Professor Amin Khwaja, who's the outgoing president. The vice president, outgoing vice president, Dr. Ali Sarfaraz. मेरे ख्याल से शायद नहीं है वो. General Secretary continues, Dr. Asma Abdul Salam. Joint Secretary, Dr. Ashok Parchani. And Treasurer, Dr. Dillu Raja, the outgoing treasurer. I will also announce the names of those people who are now going to take over, and then we can hear some comments. Or should we hear the comments first and then invite the new cabinet? I think I'll request Professor Amin Khwaja for his comments.
Thank you very much. This conference was not possible without the support of Executive Committee, Cabinet members, and patron Dr. Saida, Tipu Saab, and a lot of other colleagues who were supporting us. The top of that, this was extremely important to appreciate our youngsters who, since last 1 week or more than that, working tirelessly for the scientific program, printing and publications. And I think for last 48 hours, they are staying here for these stalls and all the things. So we all should appreciate and clap for them. The important thing, very important thing is we have organized this conference without the event managers. That is very important. That gives two messages to the youngsters and for the coming cabinets. And ये हमारी बहुत पुरानी रवायत रही है. आप leadership को grow करते हैं. ये paperwork, ये invitations. I have been the general secretary for the two tenures in 13 and 14, 12 or 13. इसके बाद भी लोग आते रहे, doing all the writings, inviting the chief guest. You get a message from the PS of the high dignitaries to you. You have to write the speech for all the things. And after that, scientific program, although the scientific chairperson is one of the senior person, but again, he goes to the general secretary, he asks for the vice president. So काम इतना है, and that helps to bring the new faces or नई generation. They know how to do the communication, how to write the things. So the beauty of this conference, Dr. Saida ने कहा, हमने अपनी meetings में भी ये बात की थी. आप believe करें,
कि यही कॉन्फ्रेंस अगर हम इवेंट मैनेजर से कराते तो इट इज इन अ बिजनेस ऑफ more than 10 million, more than 10 million. I'm just saying, but we have done very, very less amount. ज़्यादा हमारा खर्चा होगा तो होटल का होगा, जो रेट्स हैं, otherwise there's nothing. तो ये ट्रेडिशन बरकरार है और ये कमिंग डेज में भी बरकरार रहेगा क्योंकि लीडरशिप तैयार हो रही है, यंगस्टर्स आगे आ रहे हैं और टॉप ऑफ दैट इससे एकेडमिक एक्टिविटीज भी बढ़ रही हैं. आई डू रिमेम्बर आज से अगर हम 30 साल पहले चले जाएं तो MCPS वाज द बेंचमार्क. अब फेलोशिप तो एवरीवन इज डूइंग द फेलोशिप. So this is because and society is providing an platform academic activities और ये सब जैसे जिस तरह से पोस्टर प्रेजेंटेशंस हुई हैं, oral talks हुई हैं, you can see that reflects your hospitals, what they are doing in their hospital. कि आप अगर international studies को compare करें, आप अपने बच्चों को देखें कि they all are doing same thing. So congratulations to all the seniors who have looked after their juniors during this. और इसके बाद I am thankful to cabinet, इसके बाद executive committee, Dr. Saida, Dr. Tipu, and this conference की सबसे अच्छी बात, जिसी भी कामयाबी ये है कि आपके senior colleagues out of city और दूसरे provinces से आए. So we have got more than 50 delegates from senior delegates from the Pakistan, and I'm thankful to them. They all are very busy. हर एक की practices हैं, अपनी commitments हैं, और आजकल वैसे भी शादियों का season है. Everyone is busy, लेकिन सब चीजें छोड़ के वो लोग यहाँ पे आए और participate किया. I'm thankful to them, और hope in coming days that thing same tradition will continue. Thank you, Dr. Saida.
Thank you, Amin Khaja. And let me have the pleasure of announcing the names of the new cabinet. The president for the year 2023-24 for the Karachi chapter would be Dr. Shabir Jumani. President-elect by consensus is Dr. Hamid Ali. Vice President is Dr. Dillu Raja. General Secretary, Dr. Asma Abdul Salam continues. General Secretary 2 terms करता है कम से कम हमारे यहाँ. Joint Secretary, Dr. Dilip Kumar. Dilip is not here? Okay. And Treasurer, Dr. Talal Ahmed. I will also read out the names of the executive members. Dr. Akhtar Aziz Khan, Professor Fawzia Anis Khan, Professor Sadqa Aftab, Professor Nurul Haq, Professor Zahid Akhtar Rao, Professor Safia Zafar Siddiqui, Professor Gohar Afshan, Professor Nighat Abbas, Professor Samina Ismail, Professor Alia Ahmed, Professor Amin Khwaja, Dr. Muhammad Hamid, Dr. Amin Anwar, Dr. Zahid Salod, Dr. Amin Suleiman, Dr. Syed Farjad Sultan, Dr. Zia Akhtar, Dr. Ali Sarfaraz, Dr. Nabila Nasir, Dr. Shoaib Malik, Dr. Muhammad Abbas, Dr. Hamid Ali to upar aa gaye, Dr. Aftab Ahmed Khatri, Dr. Nasir Ali Rahimi Nijad, Dr. Nasir Khoso, and Dr. Kinza Ehsan. Our overseas coordinator, and he's really been very good, is Dr. Kashif Iqbal. I would request Dr. Shabir Jumani to come here and say a few words.
Bismillah ar-Rahman ar-Rahim. Nahmadu wa nusalli ala Rasulihil Kareem. I feel humbled. I'm thankful. It's a wonderful moment for me, to say a few words. I first saw the conference in 1983. It was my first conference organized by PSA. And it has been almost 40 years since then, I'm here attending these conferences. And the evolution of the society is, before me. My seniors, particularly Professor Tipu Sultan and Professor Saida Haider, have done a wonderful job, in evolution with the society. And I hope that with the help of you people and the cabinet, we will achieve the standards, set by these, and it will continue, inshallah. Thank you very much.
Hello, that concludes the business session, and now two more interesting sessions. I would invite Noor for the, kya kehlata hai ye? Lottery session. That is another business. Okay, now real business session. Okay, and after that, huh? Cabinet की तस्वीर. मैं भी बैठ जाऊँ. चलो.
I must announce that Dr. Saida Haider continues to be the patron of Karachi chapter, and Professor Tipu Sultan continues to be patron of center.
Now Noor will take over, and ये एक interesting session है जिसमें आप लोगों को देखें किसकी किस्मत जागेगी, और उसके बाद उससे अच्छा session है कि हमारा पेट पूजा होगी इंशाल्लाह. तो दमपुख्त में होगा for the juniors. It's in Dampukht, and for the very senior member can go to the Governor House inshallah.
चलिए जी शुरू करते हैं. भूख बहुत लगी है, तो पहले मेरे ख्याल में first of all, Aftab Life Care, please come with the Aftab Life Care का कहाँ है सामान? यहाँ रखें लग. और आपका डब्बा किधर है? लक्की ड्रॉ का. And ask Dr. Saida, please come on the stage. हाँ, देंगी ना लोगों को, सबको बुलाते हैं. अच्छा, तो हमारे प्रेसिडेंट साहब आ जाएं. हाँ, शब्बीर जुमानी, प्लीज कम ऑन द स्टेज. लाओ भाई लक्की ड्रॉ डब्बा लाओ. डब्बा कहाँ है? नहीं, उसमें निकाला नहीं. हाँ ले आओ बाजवा को. बाजवा वाले का आप डब्बा नहीं रखा. इंडस वालों को प्लीज इंडस प्लीज कम ऑन स्टेज. हाँ जल्दी जल्दी आ जाए. दो निकाल. Dr. Preeti. Dr. Preeti, NICVD. नहीं. डॉक्टर प्रीत, अच्छा देखिए रूल ये है कि इसको एक दफा इनाम मिलेगा, नेक्स्ट इनाम में अगर निकलेगा तो उसको नहीं आएगा, मिलेगा. ठीक है ना? ही इज जो मौजूद है उसको मिलेगा. नंबर 2, डॉक्टर जिया अख्तर. इज ही हियर? नहीं है तो निकाल लें दूसरा. डॉक्टर तीसरा निकाल. डॉक्टर जिया नहीं है. तो इतना बंद नहीं करो भाई. अभी ये पकड़ो. ये ठीक. डॉक्टर सहर खान CHK. डॉक्टर सहर खान CHK. चलो ये लो तुम्हारे तुम्हारा तुम्हारा दो ही नाम था जी। Usman ko please come on the stage with your lucky draws and all that. Dr. Zahid Rao, please come on the stage. Lucky draw नहीं था? डब्बा नहीं? नाम बताइए कौन सा? आपके कौन कौन से? नहीं 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 अच्छा ठीक है ठीक है ठीक है ठीक है नहीं ये तो उन्होंने लिस्ट देखी ये वाली ना तो उन्होंने लकी अच्छा तो डॉक्टर उताबा डॉक्टर वकास इंडस हॉस्पिटल डॉक्टर फरहान सॉरी डॉक्टर फरहान फ्रॉम इंडस हॉस्पिटल डॉक्टर ओसामा असद खत्री फ्रॉम ट्रॉमा सेंटर ओसामा साहब ऊपर आ जाए पहले कमर साहब से आपके 4 हो गए ना डॉक्टर स्वाले खासखेली का इन्होंने नाम दिया जो कि बाहर से आए इसलिए इनको दिया जा रहा है डॉक्टर स्वाले खासखेली चले गए अच्छा डॉक्टर उमर शेख द सीनियर मोस्ट ऑफ हियर इज हियर डॉक्टर मोहम्मद हामिद खान डॉक्टर हामिद अली फ्रॉम अब्बासी शहीद डॉक्टर अरसलान डॉक्टर आयशा जमाल डॉक्टर आसमा आ जाए जीएस सर आप आ जाइए हाँ? हमारे हमारे मेहमान हैं लाहौर से आए हैं इस्मत वसीम चौधरी प्रोफेसर इस्मत वसीम चौधरी फ्रॉम लाहौर थैंक यू उस्मान को असूका प्लीज विद द लक्की विद द डब्बा डॉक्टर सईदा आप आ जाएं आप निकाल लें नहीं उनका नहीं देर से आया तुम्हारा तो चला गया तो चला गया कहाँ थे तुम वॉशरूम गलत वॉशरूम गए थे ना डॉक्टर इमरान सरवर फ्रॉम सिविल हॉस्पिटल कराची नहीं है डॉक्टर मिनहाजुद्दीन फ्रॉम कुरंगी गोट कोही गोट हॉस्पिटल नहीं है डॉक्टर नूर आलम फ्रॉम SIUT नूर आलम फ्रॉम SIUT नहीं है नूर आलम हाँ ठीक है आप बैठे आपको बुलाते हैं अभी हम डॉक्टर रमेश कुमार फ्रॉम THQ तालका हेल्थ हॉस्पिटल डॉक्टर उमर शेख सीनियर हमारे कंसल्टेंट हैं उनके लिए एक इनाम रखा है उमर शेख साहब प्लीज कम ऑन द स्टेज प्लीज उठा लेंगे ना सर डॉक्टर नबीला सोमरो डॉक्टर नबीला सोमरो फ्रॉम SIUT हैं बाहर हैं ठीक है बाहर ही पहुंचा देते हैं ठीक है ना डॉक्टर सलमान शौकत NICVD भरा क्यों था भाई जब डॉक्टर अब्दुल्ला फ्रॉम SIUT डॉक्टर नौरीन परवेज जल्दी जल्दी आए देर नहीं कर रहे थे दो बार नईम शेख फ्रॉम AKU
नईम शेख AKU
नईम शेख डॉक्टर किन्जा जहरा ठीक एक और ले लीजिए हम पढ़ देंगे फरासत फ्रॉम LRBT डॉक्टर फरासत है यहाँ पे डॉक्टर सलमान Dr. Adil from SMBBIT. नाम क्या बेटा? अच्छा, प्लीज आफ्ताब लाइफ केयर, प्लीज कम ऑन द स्टेज. ठीक. Dr. Nasir Khoso from South City. Is he here? Dr. Faisal from SIUT. Zahid bhai, आप आ जाए. Dr. Faisal है ना? Dr. Arshad from LNH. Dr. Arshad चले गए. Dr. Fauzia from JPMC. Dr. Ashok Kumar from Civil Hospital Karachi. Dr. Zahid Silod from Kurtalain Hospital. नहीं है वो भी. Dr. Arsalan. Dr. Arsalan. आपके तो दो लोग एब्सेंट हैं, नासिर खोसो साहब, आप उनको दे देंगे. ठीक है, ओके. Bajwa, please come on the stage. जैसे ना उसको पास करने टाइम बहुत लग जाएगा. बाकी वैसे दे देंगे. ठीक. वो ये बाजवा की तरफ से है, लेकिन इन्होंने कुछ 4 लोगों के नाम निकले थे, इन्होंने हमें वो दिए हैं. एक डॉक्टर सफिया जफर, डॉक्टर जाहिद राव, इन्होंने अप्रिसिएशन पे दिया है कि आपने इतना अच्छा कांग्रेस किया है, तो इसलिए अब मिल रहा है. डॉक्टर नासिर फ्रॉम इंडस हॉस्पिटल. डॉक्टर विनोद फ्रॉम इंडस हॉस्पिटल. ठीक. हाँ ठीक. आप अपना ले तो ले, रख दें ना. जिनका नाम निकला था वो यहाँ नहीं थे और अब हैं, तो वो प्लीज फॉरवर्ड आ जाएं ताकि उनको इनाम दे दिया जाए. बाकी हाँ, नए नाम, बट डब्बा लाओ ना अपना. डॉक्टर जाहिद प्लीज आए ना, निकाल लेना आप. डॉक्टर सादका आप भी आ जाएं प्लीज. आगे आ जाए बेटा, डब्बा इधर ले आए, इधर ले आए, डब्बा करीब लाए. डॉक्टर आरिफ नकवी. डॉक्टर आरिफ नकवी प्लीज फ्रॉम फातिमिया हॉस्पिटल. अरे कहाँ है? आ जाए मेरा, ऊपर आ जाए. डॉक्टर सूरज प्लीज. Dr. Komal. हमारे बॉस नहीं होंगे। डॉक्टर आयश में इनको तो आयशा को मिल चुका है मेरे ख्याल में, इफ आई एम नॉट रॉन्ग। डॉक्टर सिद्रा जावेद फ्रॉम SMBBIT। सिद्रा जावेद है? ये क्या नाम क्या है? ये कोई LNH से है, रफी नाम है क्या? रफी नाम है? फ्रॉम LNH रफी है कोई? इन्होंने नाम ही ऐसा लिखा है कि बैड लक। ये वही नाम है, निकल चुका है पहले। डॉक्टर यमुना शाहिद। डॉक्टर मुबीन। डॉक्टर मुबीन कौन है? डॉक्टर मुबीन फ्रॉम हमदर्द। किसी और डिपार्टमेंट के होंगे। नहीं है तो ठीक है। डॉक्टर शम्स शेख फ्रॉम इसरा यूनिवर्सिटी। शम्स शेख फ्रॉम इसरा यूनिवर्सिटी है? अच्छा, SIT के नूर आलम आगे आ जाओ भाई ऊपर को। SIT के नूर आलम कितने रह गए आपके? ये क्या लिखा है? नाम नाम तो बताएं, पढ़ के क्या लिखा है? महरीन आफरीन है कोई? या मलीहा आरफीन? मलीहा आरफीन। ओके बेटा, नाम तो सही लिखो वरना रह जाओगे पीछे हमेशा। कहाँ थे बेटा? किस इंस्टीट्यूशन से? किससे हो? किस इंस्टीट्यूशन से हो? हाँ ठीक है, ओके दैट्स नाम साफ लिखा कर भाई। Thank you, Bajwa. Now I would like to call the FDL. Please come on the stage. हरमित और ठीक है, जो है ले लो। FDL की 4 हैं। नहीं मना किया। अच्छा, FDL please come on the stage. उनको बुलाओ, बॉस को। डॉक्टर इस्मत प्लीज कम ऑन द स्टेज, और ताकि आप हाँ वो कर लें साथ में के। हाँ भला चौधरी को आपके दोस्त हैं ये तो। लकी ड्रॉ में तुम्हें वो नाम वही है? डॉक्टर फरजाद प्लीज।
मेरे नाम है आपके पास?
नहीं नाम नहीं,
कोई
तो
किसी एक
कर
कार्ड-
दिया
मैं कार्ड दे देता हूँ।
ये सबको दे दिया मैंने।
हाँ, आप खुद ही बता रहे
हाँ, और बताओ नाम बताओ।
आप किसका दूसरा
Please come on the stage. वो वापस ले लेंगे इनकी तरफ से। ये मेरे पास नाम आए हैं कंपनी की तरफ से, उन्होंने थैंक्स किया है। डॉक्टर सईदा हैदर। Dr. Dillu Raja, please come on the stage. FDL कुछ announcement करना चाहता है and he needs 1 minute. Please come. No, are you?
My name is Saeed Akhtar, and we are supplying IV infusions in Pakistan market. I don't have much to say, but I have just a token of my hearty gratitude for Dr. Noor for the successful decade of 3 decades and the professional reciprocity. Dr. Noor, please give him a very big hand. Thank you.
Thank you.
No, thank you.
ये हमारे जो वर्कर्स नहीं मिले हैं उनको दे दिया जाएगा इंशाल्लाह। थैंक यू वेरी मच। अब खाना तैयार है और हम लोग चलते हैं। सीनियर्स जो हैं वो गवर्नर्स रूम में और जो जूनियर्स हैं वो आपके दमपुक में हैं। तो प्लीज दमपुक में सब पहुंचे। सीनियर्स अभी रुक जाएं यहाँ पे 10 मिनट।